Am I audible, visible? I hope I'm audible, visible. Okay. So I'll start. Sorry for the late starting. It's not my, mistake. I'll cover as many subjects as possible. Don't worry. Okay. And yes, the classes will be there till the exam. Hopefully, not just exam, after exam also. And it'll be available for all of you. 33 pages. We'll be finishing them today. And we'll be having the, yes, grand session of medicine today. So I want all to give me their 100% attention, because it will cover at least 10 to 15 MCQs. Already I've shared all the files in the PDF, okay, form. So if you want, you can message me. I will cover. Yes. So I'll cover this PSM, okay, and I'll try to be as much as possible. Only issue is 9 p.m. Again, there's a issue. Again, a session. So I have to finish anything by 9 p.m. So cutoff is 9 p.m. So try to finish as much as possible in the 9 p.m. category. Okay, so let's start. First is, what are we discussing? We are discussing with endocrine system. So diabetes, we know there is a triad of what? Polyuria, polydipsia, and also the weight loss. So the triad is polyuria and weight loss. Now diabetes could be mellitus or insipidus. Main difference is sugar profile. If there's an abnormal sugar profile, it is diabetes mellitus, otherwise it's insipidus. That's why earlier time the doctors, when a patient has too much urine, that is diabetes. Polyuria is diabetes and abnormal sugar is mellitus. So earlier time doctors used to taste the urine to tell it is mellitus or insipidus. I'm not joking, okay? So taste, oh, meetha meetha, meetha meetha, mellitus. If it's tasteless, it is insipidus. So the literal meaning of word insipid is tasteless. So that is the case, okay? Screen is half visible. Oh, 1 second, okay? Let me check the setting. Now it's better. See, the resolution was not set, so I have to change it. I think now it's okay. Fine now. Yeah, I think now it's okay. Okay, so polyuria, polydipsia, weight loss, and that's why urine tasting was done in the earlier time. Now we all know physiology. Insulin comes from the beta cell of pancreas via GLUT2, and it shifts glucose from blood to cell via GLUT4. Remember, physiology also I'm covering via GLUT4. MCQ. And it causes weight gain because the glucose goes to cell, anabolic action. So that's which hormone causes weight gain? Increase in the, yes, anabolic action, that is insulin. Also decrease blood glucose, ketones, and potassium. So what three things it decrease? It decrease our, yes, what three things it decrease? It decrease the ketones and potassium. Okay, now diabetes can be multiple time, which I'll see later. Now what are the clinical features? Sweet urine mellitus, then it is insulin related mellitus, polyuria, polydipsia, and weight loss. Why? Because of less GLUT4. So that's why what increases? Blood glucose increase, potassium increase, hyperkalemia, and also ketones occur with weight loss and polyphagia. Okay, now what is the types? Neurogenic, nephrogenic, diabetes insipidus, ADH defect is there. Okay, now sugar profile. For fasting blood sugar, normal is less than 100. Okay, and if it is more than equal to 126, it is diabetes mellitus. Impaired or pre-diabetic, pre-diabetes is 100 to 125. So it's 100 to 125. Then GTT. Remember GTT we do after 2 hours. So after 2 hours of glucose, oral glucose, we check the blood sugar. If it is 200 double century, then congratulations, you're not Sachin Tendulkar, you are diabetic. So double century is diabetes, double century is diabetes. 140 below is normal. 140 to 149 is again impaired glucose tolerance. Best is HbA1c, which is glycated hemoglobin. It is giving 3 level. So that's why it is for long term glycemic control. So what give long term glycemic control and best prognosis? So it is given by our HbA1c. What is the level? Remember, mnemonic I made 5665. Panja chakka, chakka panja in Hindi. So 5-6 is normal, 6-5 is diabetes. So if 6 come first, 6, it is diabetes. Double century, 6. So 6-5 is diabetes, 5-6 is normal. If it is 5.7 to 6.1, it is impaired, yes, value. Now there are two types of diabetes. One is DM1 and DM2. In DM1, just remember, less insulin is there because of destruction of beta cell. Mostly autoimmune, but can be idiopathic also. Type 2, there is a insulin resistance. Insulin is there, but it cannot act. So that is why there is a resistance, and this resistance is very commonly because of what? Receptor downregulation. So that's why middle-aged people, 40, 50-year obese, then they are older in age. Insulin can be normal or increase along with C-peptide. Also increase C-peptide. So if you see increase insulin and increase C-peptide, what are we suspecting? We are suspecting DM2. Whereas young people, juvenile diabetes is type 1. There is autoimmune, so HLA involved is HLA, DR3, 4, and also the, yes, DQI or AQ1. It's AQ1, not DQI, but just get it. Okay, so AQ1. Okay. Now comes the question, insulin is less. That's why treatment is give the insulin. That's why it's called as insulin dependent diabetes mellitus. Are you clear? So it's called as insulin dependent diabetes mellitus. Here insulin or C-peptide is okay. Now family history is not present. Here there is a family history, and that is why it is also called as what? Non-insulin dependent. Why? Because there is, yes, insulin level which are normal or high. Here we use oral hypoglycemic agent like metformin or Conn or gliflozins. Okay. Now LADA. LADA is basically old people, Dadaji. LADA in Dada, LADA, Dada. And Dadaji has antibody GADA, LADA, DADA, GADA. So what are the antibody? GAD, glutamic acid decarboxylase antibody is present, and is diabetes 1 in old people. So remember, if young people antibody, DM1. Old people antibody, LADA. If there is genetic history in a younger person, less than 25, it is MODY, maturity onset diabetes of young. There are no antibody but genetic history. Like example, alpha 1, HNF alpha gene mutation, and it's autosomal dominant disease. Most common is type 3. What is the most common? Type 3 is most common. So what is most common? Type 3 is most common. Okay, done. Now summary I am giving again in my style. So I am giving a summary, and the PDF I am going to upload in the group. So don't worry at all, everything will be there. So I'll just give a summary in my style. Remember this table, make it in the exam, and it will help you solve the question. Make a table like this. Okay, young, old, antibody, and genetic or family history. Genetic or family history. So first is, if they mention young person with antibody, what is the diagnosis? Diagnosis, yes, it will be DM1. Actually DM1A. Okay, B is idiopathic. If it is older, it is LADA, and LADA में दादाजी हैं और गाढ़ा है. LADA, गाढ़ा, LADA, गाढ़ा, गाढ़ा, and it is MODY, MODY G, and MODY G is very dominant person. Yeah, I will upload the file. Already uploaded. Just message me at this number. I will send you the file. I have given it to DBMCI, all the groups. I don't know why still people have difficulty finding. So it is MODY. If this, it is DM2. And remember, there is insulin resistance in this case. Others are insulin sensitive. Why? Because all this condition insulin is low. So remember, in DM2, there is normal or increased insulin, and all others, there is less insulin. That is why they all are insulin sensitive. MCQ. So they all are insulin sensitive. We can give insulin to all these people. So where can we give insulin? DM1A we can give insulin, LADA we can give insulin, MODY we can give insulin. Okay, DM2 we use OHA. So that is why all other treatment is mainly insulin. Okay, all others. So remember this table. So LADA, DADA, GADA, DADA. So LADA, DADA. Okay, and MODY is young, MODY ji. Most common is type 3. So remember, who will come third time also? अब की बार फिर से किसकी सरकार? 2024 again मोदी जी. So remember, 3-time prime minister मोदी जी. So MODY is type 3, most common type 3. Okay, now next question, what is the longest acting insulin? It is D-glutamate, which is more than 48 hours. Now type 2 is refractory, that is why in type 2 we use insulin if it's refractory. So if you ask what is the treatment of DM1, insulin. Then what is the treatment of MODY? Insulin. DM2, refractory, insulin. Pregnancy, insulin. So all this condition, insulin is the drug of choice. Now treatment of DM2, lifestyle modification. Be like MODY ji, that is no alcohol, no smoking, no marriage, sorry, by mistake I said. So be like MODY ji, that is exercise, yoga, positive thought, everything. Okay, weight loss, exercise, then have what? Food, low glycemic index, less. So that is what MODY ji is. So be like MODY ji. Okay, now metformin is the drug of choice. Metformin decrease mechanism of action, decrease liver glucose, so it is causing weight loss also. Some books say weight loss is plus minus, so I will put plus minus. Okay, some books say it cause the weight loss, some say don't cause the weight loss in this case. Okay, fine. Okay, now what is metformin? Side effect is it is lactic acidosis and B12 deficiencies are the two side effects of metformin, and it is contraindicated in pregnancy, alcoholic and liver disease. Are you clear? And fenformin is completely banned because of severe lactic acidosis. Now comes sulfonylurea. They are all mites. They are all mite. Tolbutamide, glibenclamide. So these are basically glyceride. They basically increase insulin by closing the potassium channel. Then come TZD, that is yes, thiazolidine. Thiazolidine. They decrease the resistance to which substance? They decrease the resistance to insulin. Or the name of drug? It is Rosi and Pio. Rosi. So Rose Pio, yeah, Rosi Pio. Nowadays they are banned because they are causing cardiac side effects. Okay. Then AGI, alpha glucosidase inhibitor. They inhibit the starch absorption in GIT. Okay. That's why they cause what? Side effect is flatulence, diarrhea. If you give someone this acarbose, miglitol, what they happen? The person become rocket thing. So he will fart so much. Then if you put fire, he become a rocket. So that's why remember it's not used very commonly. Okay. Then DPP4 inhibitors are gliptins, and gliptins are all female name. Why? Females talk very sweetly. So Sita Mata, Saksha, then Rita ni Leena hai. Okay. Chalo. Rita, Vilda. So they are all gliptins. So they are all gliptins. And in renal disease, what do you need to take? Lena hai, Lena hai. So linagliptin is used in renal diseases. So it is in renal disease used. Okay. And what they do? They increase GLP and GIP, which increase the insulin because they are insulin secretogogues. Okay. Now comes the question, SGLT2 inhibitor. They prevent glucose reabsorption in kidney by inhibiting what? SGLT, that is sodium glucose link transport 2. So they block what? Sodium glucose link transport. They increase the what? They increase the blood glucose. So that's what the side effect. What the side effect is? Yes, high glucose in the urine. So increase urine glucose. Increase urine glucose. Side effect is UTI. So what is the side effect? UTI. And the two drug, Canna, Dapa and AMPA. So remember mnemonic CDE, and they are causing flow of glucose in urine. So glucose flow in urine. What is the mnemonic? Glucose flow urine. So now you will never forget the name gliflozin. So glucose flow in urine, gliflozin. So it is gliflozin. They are used for both DM1 and DM2. What drug? Acarbose, pramlintide increases amylin. Okay, so that's why they can be used in both. Okay, now what is the management of DM2? Target is HbA1c less than 7%. That's the target. So what we start with? Weight loss, lifestyle modification, MODY ji, and metformin. If metformin is contraindicated, what drug we can use? We can use SGLT2 inhibitor. Then for 3 months we do. Why 3 months? Why 3 months? Question for you. Why we are giving for 3 months? Reason. Yes, HbA1c need at least 3 months to be showing the status. So that's why it takes 3 months of observation to have a change in HbA1c. Like if I start treatment now, my HbA1c will not be showing the change. Now it will show after, yes. If you want 2 weeks, for 2 weeks we can use fructosamine. So fructosamine give you 2 week reflection. Now, if not control, we can add another OH chain. Which OHA we can add? Let's say sulfonylurea we can add, or we can use the gliptins. So OHA. And now for 3 months, again continue. Now we add 2 OHA for 3 months. If it is not responding even after 3 drugs and 9 months, then it is called as resistant diabetes. Now the drug of choice is insulin. So we can also use insulin if the HbA1c is more than 9%. We can use the insulin in this case. Okay. Now what are the diabetes complications? So remember, diabetes mellitus. If they ask you what is the complications, I will just give a very simple and brief summary. It is nephropathy, diabetic nephropathy, and they ask you earliest change, earliest. So what are the earliest? Earliest is your microalbuminuria, MCQ, microalbuminuria. But hallmark is Kimmelston, Wilson, nodular glomerulosclerosis. So that is your hallmark. So the main disease, Kimmelston, Wilson, nodular glomerulosclerosis, MCQ. Then if they ask you what is the effect on nerve, it causes your neuropathy. So diabetic neuropathy. But question, first to loss is vibration. And later it caused neuropathy, glove and stocking pattern, also caused Charcot joint because of what? Loss of joint sensation. So also cause the high stepping gait. So many features are there. And in ophtha, retinopathy, I told you what are the finding. Earliest is microaneurysm, and hallmark is what? It is your what? Neovascularization. Now, second is diabetic ketoacidosis. For the trigger is infection. Most common is infection, stress, or uncontrolled diabetes is there. Now what are the finding? There is metabolic acidosis with increased anion gap, and it's a HAGMA, high anion gap metabolic acidosis. I will discuss it very soon, the HAGMA, and this hopefully I will covering. So there are two kind, HAGMA and NAGMA, which I'll cover very well. Okay. Then pH is obviously acidosis less than 7.3 and bicarb is less than 24, which indicate metabolic acidosis. Then sugar level will be more than 250. Ketones are present in blood and urine. We can do by dipstick. And respiration. Remember, there is a acidosis. So what will acidosis do? So remember, low pH acidosis. So acidosis trigger rapid breathing called as the Kussmaul's breathing. And there is also fruity smell, smell. Why? Because of acetone, which is a ketone body. Then there is increased heart rate but decreased BP, shock because of dehydration, vomiting, etc. is there, abdominal pain. Patient can be drowsy and conscious also. So that's why remember, in treatment, first we will always start high rate normal saline. And then drug of choice, if they ask, is regular insulin. How much? 0.1 unit. Initially we can even give 0.15 unit as the loading dose, but main is 0.1 unit per kg per hour. Then we can add bicarb for correction of acidosis, and also we can give potassium supplements. Are you clear? But what is the main drug? So main drug is our which one? It is our, yes, insulin. And what is given first? Always start with high rate normal saline. Okay, high rate. Ringer is not preferred here, is already in acidosis, so avoid ringer, use normal saline. Now come adrenal gland. It is two-part, cortex which makes steroids, and the medulla which is making what? Catecholamine, epinephrine, norepinephrine, dopamine. They are made by chromaffin cell. Now Pheochromocytoma follow 10% rule. And what is the 10% rule? 10% malignant, 10% are bilateral, 10% are extraadrenal, 10% malignant. And what is the family? They belong to MEN2A. Okay. Yes. Also called as what? Yes. It is called as what? Sippel syndrome. Now what happens? If there's an increase in the norepinephrine, which via alpha-1 cause vasoconstriction and via beta-1 causes the heart to increase the BP. So that's why there's a very high increase in the BP. So classical triad is palpitation. Again, why? Because of increased heart rate. Sweating is there again because of beta receptor, and headache is there. Most common finding is headache, which are episodic in nature, not sustained, but mainly they are episodic and not long, short lasting. Now postural hypotension is there. Why? Mainly because of polyuria, there's decreased circulatory blood volume. So when the person stand, he can faint. So postural hypertension, polyuria due to high BP called as pressure diuresis. So the patient is having pressure diuresis. Are you clear? Now, what are the screening? And remember, beta blocker, I'll discuss. Screening is 24-hour fractionated. It's fractionated urine, metanephrine and VMA. Metanephrine is superior to VMA level. Are you clear? Then we can have investigation of choice, or the best is plasma free metanephrine. Okay, it's for confirmation. So confirmation, and then we'll do MRI for location size. No biopsy. Why? It's a very dangerous. It releases the catecholamine which can cause our crisis. So that's why don't do biopsy. Okay. And in carcinoid, what is increased? 5-HA, indole acetic acid, 5-hydroxy indole acetic acid. And carcinoid tried is what? It has sweating. Yep, you can have flushing, clinical feature, and the wheezing. So if they say flushing, wheezing, think of carcinoid, and the marker is 5-HIAA. Okay. Now, treatment is surgical removal, but give alpha-1 blocker before the surgery. Alpha-1 blocker, okay. What is contraindicated? Beta blocker. Last year NEET PG. Beta blocker alone should not be given. Why? Because beta blocker alone, what is the problem? Problem is they are not sufficiently able to do the correction of BP. Rather, beta blockers can cause what? Problem in they are not going to affect the alpha, and they only block the beta. And beta 2 cause vasodilation. If you block them, rather they cause vasoconstriction. So not preferred. Okay. So that's why what the drug of choice. First we start with pre-operative volume. I think I'm loud enough, Sheetal. I'll just try to check my volume. They are not going to. Okay. I'll just try to increase the volume. Don't worry. Okay. Okay, so am I audible and loud and clear now? Okay, Sheetal, what do you think? Am I loud now? So we increase the volume. Okay, so am I audible? I think now I'm loud. Okay, so let's start. So now before the surgery, remember BBB. So before the surgery we give. So benzamine is given before the surgery, and it's given orally. Then in the OT, intra-op, tolamine. So intra-op we give tolamine, and post-op we give labetalol, which is alpha-1 beta-1 blocker. Okay. In crisis we give phentolamine plus labetalol plus labetalol plus nitroprusside can be added. Okay. Now we see Cushing syndrome. Now Cushing syndrome is basically increased cortisol from adrenal gland, or it could be iatrogenic. Most common is iatrogenic. Now if there is an increased cortisol, it will decrease ACTH, so no pigmentation. So pigmentation is absent. But if there is a cortisol coming because of the ACTH from the pituitary adenoma, then there could be pigmentation. So that's why this I'll discuss later. Now, what are the earliest features? Loss of diurnal rhythm. So what are the earliest? It is loss of di. Then thin limbs are there. Why? Because of wasting done by steroid. And there is also obesity. Abdomen is showing the accumulation of fat, plus face become moon shape because of high salt retention. And there's a buffalo hump. And abdominal obesity or camel hump. That's why it give a classical lemon on stick. Very thin limb, abdomen is big, stria are formed. So what are there? Also stria, that is stretch mark, which could be red, violet, even white. Then apple red cheek because of polycythemia, high BP, high sodium, hyperglycemia, diabetes, poor immunity, poor wound healing. So poor wound healing, all are feature of this disorder. Also osteoporosis is there, codfish vertebra. So poor wound healing, codfish vertebra due to osteoporosis. So many findings are there. So codfish, vertebrae, all are seen. Now, what is the investigation initial? We do 24-hour urine cortisol level. It is increased 3 times. And what is the investigation of choice or the best? It is dexamethasone suppression test. If you give, it should decrease. But if the level are high, it confirm Cushing. So that's why high cortisol confirm Cushing. Now it could be a Cushing disease or syndrome. How do you do? If ACTH is high, it is due to pituitary adenoma, that is disease. So both are high. Remember, in disease, both ACTH, cortisol high. So dual increase. What is increase? Dual increase. There is dual increase. High ACTH, high cortisol. Okay. But if there is a syndrome, ACTH is low, cortisol high. Only single increase. Are you clear now? Yeah, we'll discuss, don't worry. Circle of Willis I'll discuss later in detail. Okay, clear? So ACTH will be high in this case. Are you clear? So ACTH is please, okay. Low ACTH and cortisol. So if there's a single increase, what increase? Single. So what single? Cortisol is increase. And that is syndrome. Okay. Now what we do? If it's a pituitary adenoma, we will do the transsphenoidal resection. But before that, we can give the adenoma. How do you decrease the adenoma? So we will decrease the size of adenoma by giving cabergoline or bromocriptine, which is dopamine agonist. They shrink the size of tumor. So the drug of choice of adenoma is cabergoline and bromocriptine. And with the classical hallmark, it is headache, clinical feature, headache, and bitemporal hemianopia. Bitemporal hemianopia is a hallmark of what disease? Our pituitary adenoma. Okay. Now, if there's a Cushing syndrome, it can be either adrenal adenoma or exogenous steroid or exogenous steroid. Second, high ACTH also cause what? Acanthosis nigricans. Acanthosis nigricans, which is in axilla most commonly. So that is the simple finding. So if you get acanthosis, it is most likely ACTH Cushing disease. If there is no pigmentation absent, it is most likely Cushing syndrome. Take a history. If taking steroid, it is Cushing syndrome because of iatrogenic intake of steroid. Now, treatment is resection of adrenal adenoma. And if you are using the steroid, then gradually taper the dose. Do not stop steroid abruptly, else Addisonian crisis will occur. Now, Addison disease is a reversal of Cushing. That is, there is low level of steroids. Okay. So it is what? It could be pituitary lesion, secondary, or primary is what disorder? Primary is your adrenal insufficiency. Okay. Here, what decreases? Cortisol decrease, aldosterone decrease, and also decrease sex drive, mainly DHEA. DHEA. That's dihydroepiandrosterone. Now, if cortisol is less, there is what? Decreased BP, metabolic acidosis, high potassium, low sodium, okay, and increased potassium, which I discussed already. Clear? And there is intense salt craving. So person want to eat as much salt as possible. Then weakness is there, muscle wasting is there. So all are findings of what? Of our Addison. And person can go even in coma. So in India, most common cause is infection with TB. Worldwide, it is autoimmune. Autoimmune is worldwide cause of Addison's disease. Okay. Now, investigation, low serum sodium, less than 135. Best test is ACTH stimulation test. If there is increased cortisol after giving the ACTH, it indicates pituitary is not making ACTH. It's a pituitary lesion. That is a secondary disease. But if there is low ACTH despite ACTH, that is, we give this cosintropin test. It indicates adrenal insufficiency. Are you clear? So that's why low cortisol means adrenal insufficiency, and if cortisol increase on giving ACTH, it indicates pituitary lesion. Treatment is obviously we give hydrocortisone fluid. Okay, hydrocortisone and the fluid and DHEA. Why DHEA? To resynthesize and make our sex steroids. Okay. Now in Addisonian crisis, we give IV hydrocortisone. So what is given? IV and also electrolytes, because there is a low sodium level. I hope it's clear. So summary, Cushing is what? Cushing is obesity with thin limb, and there is high sodium, low potassium, also high glucose. Reversal is our Addison's disease. In Addison, low cortisol. What is the reason? Either gland is damaged, it could be infection or autoimmune, or pituitary lesion is there, like necrosis of pituitary, Sheehan, and that causes your secondary Addison's disease. Okay. Cones is basically cone, na 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 na. So there is too much na 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 na. So cone is na cones, sodium, and it is because of what? Aldosterone to be increased. Most commonly is because of adrenal adenoma or hyperplasia. Hyperplasia is the most common cause. So the most common cause, bilateral adrenal hyperplasia is the most common. There is an increased sodium but decreased potassium and metabolic alkalosis. There is no obesity and no edema. MCQ. So no obesity, no edema is there. Okay. And why no edema? Aldosterone escape. MCQ. By which hormone? Anyone? By A and P. So A and P cause sodium loss and prevent the edema. Now, what is the screening? Screening we will do is ALD, aldosterone renin ratio. So aldosterone renin ratio more than 750 indicate our yes cones. Confirmation we use saline or salt loading test. So we use the salt. Water loading is used for diabetes insipidus and SIADH, water deprivation test. Drug of choice is spironolactone, which is an aldosterone antagonist. Side effect is gynecomastia, taught in pharma also. Or we can use apalerenone. None. No gynecomastia. So what causes gynecomastia? Spironolactone. What doesn't cause? It is gynecomastia. Okay. I hope the speed is fine now. Is the speed fine? Actually, we have to cover everything. And you know, medicine is not a small subject, so I'm trying to go as much as possible to my best of the speed and cover as much syllabus possible as possible. Okay, now we discuss hyperparathyroidism. Basically, it is due to increased PTH, and always remember, if calcium increase, PTH increase, low phosphate and increased alkaline phosphatase with bone resorption, it is a hyperparathyroidism. In primary, remember, there's an increased calcium and increased PTH. In secondary, there is low calcium, MCQ. So if low calcium, it is secondary, and tertiary is basically a long standing. So it's what? It is a long standing secondary. Long standing secondary, okay, is called as tertiary, and in tertiary, calcium increase. So increase calcium and increase PTH. So if there is a very long term low calcium level, it causes what? Yes, it causes tertiary. In tertiary, calcium phosphate both are. Am I clear now? See, Mega, if you are doing, give your best and you are doing, I'm trying to cover all important topic in medicine. This is fine. So it will be more than sufficient to cover the maximum of medicine question. Now, what are the clinical findings? So clinical finding is stone, moan, groan. So the patient has what three feature? Stone, moan, groan. So there are psychic moans, karta rehta psychic, then groan, painful abdominal pain is there, and also there is stone formation. Plus there is subperiosteal bone resorption. I'll show the photos if you want. Okay, so let's show the photos also. So I'm showing you photos of these findings. Let's see that. Okay, so let's see the findings. So these are your findings. This is your Brown's tumor, which is basically because of what? Cyst and fluid collection. Okay, so that is the case. Then there is subperiosteal bone resorption and salt and pepper skull. So salt and pepper skull is there. Can you see black mark? They are the reabsorption lacunae, and these are finding in the bone. You can see black area. They are reabsorption areas, and this black again are subperiosteal bone resorption. And spine is rugged Jersey spine. So rugged Jersey spine is there. So rugged Jersey spine. Let's come back. So rugged Jersey spine, salt pepper skull, brown tumor, which is osteoclastic lesion, and treatment is what? We can give loop diuretics to increase the calcium, teriparatide, which is for stimulation of osteoblast, also bisphosphonate like alendronate, they increase what? They will prevent the bone resorption. Okay, and also cinacalate, and cinacalate will decrease the PTH. So these are the drug of choice. Also we can correct it via tumor. If it's tumor, we can resect the tumor. Okay, hypoparathyroidism, reverse occur. There's a decrease in calcium less than 8.5. Most commonly it is what? After thyroid surgery or dietary factors, and there is hypocalcemic tetany. Two signs are there: Trousseau sign, which is carpopedal spasm, and the caustic sign. So what is the caustic sign in this? This is the photo to show. Let me show. So what two signs are there? And this is the Kimmelston-Wilson disease kidney. I can't see it, sorry. Okay, Okay, so I kept it somewhere, I can't find it. Okay, leave it. So that is there. Okay, now come back. Treatment is we give 10% calcium gluconate or vitamin D, or we can re-implant the gland back in the body, mostly bicep brachii. We can put the gland. Okay. Now we discuss thyroid basically. So thyroid is entry of the cell in the follicles. So follicles make the thyroid. NIS, sodium iodide symport, bring the iodide. Iodide react with iodide and make what? The iodine, I2. The enzyme is TPO, thyroperoxidase, which is inhibited by carbimazole. कार में थे मजे में थे. So remember, कार में मजे में थे. So कार में मजे में थे. So कार में मजे, and it's a prodrug. Carbimazole is a prodrug. Active form is methimazole. Okay. Now the iodine combined with tyrosine and convert to MIT-DIT. MIT-DIT combined to create T3 and T4. Okay. Now T4 is less active. That's why body convert T4 into what substance? Into what? Into our, yes, by 5-D iodinase. Convert T4 to more active T3. And it is blocked by PTU. What's PTU? Propyl thiouracil. It inhibit what? The deiodinase. Now remember, it is used in pregnancy first trimester, not other condition and rest we prefer car or methi. So pregnancy hyperthyroidism we prefer PTU, pregnancy PTU, but in other condition we will prefer carbimazole or methimazole. Okay, normal TSH level are 0.5 to 5. What is the level? 0.5 to 5. If it is less than 0.5, it is hyperthyroidism. More than 5 is hypothyroidism. Why? There is an inverse relation between the two. But remember one thing: if relationship is opposite, it is your primary disorder. Like T4 increase, TSH decrease. It's a grave disease. It's a primary disorder of thyroid. But if direction is same, it's a secondary hyperthyroidism. Like in pituitary adenoma, increase TSH and increase T4. So that is why direction is same. Same is SASA, same is secondary hyperthyroidism, and primary is opposite. So primary is opposite, secondary is same. So remember this, SASA, Papa means primary means opposite, and secondary is this. Okay, fine. Now, what are the other tests we can do? RAIU. What is RAIU? Radioactive iodine uptake. What we use? We use 1, 2, 3 for diagnosis and testing. 131 is used for ablation, destruction of gland in the treatment of, yes, hyperthyroidism. And technetium 99 is also used for diagnosis. Now, normal gland, you will see black dots. These black dots show what? The gland's normal. If it is increased bilaterally, there is increased activity, it is most likely grave. In grave, there is bilateral increase in the activity. If you see one localized area of high activity, hot nodule, it's an adenoma, and less is thyroiditis. Let me show you the photos because that will be better for you. RAIU. So let's see the RAIU. This is your RAIU. Normal gland, where you can see dots. Each dot represents one follicle. So one dot is one active follicle. One dot, one active follicle. Are you clear? And too many dots, bilateral. If bilateral diffuse enlargement, it is graves. So bilateral diffuse is grave. If there are toxic multinodular, you can see multiple nodules, they are adenomas, and there could be a solitary toxic adenoma. Okay, and if the activity decrease, you see very few dots. Very few dots means what? It is hypothyroidism. Most common nowadays is thyroiditis in this case. Thyroiditis. Okay. Thank you to all of you for coming to the sessions. I am working hard because I know even if it can help 100 people, 200 people, it will be a big win. Because here our purpose as teacher is to what? Help as many students as possible by sharing our knowledge. If someone can get a good score, good rank, it will be beneficial for all of us. They will get their seat, we will get good compliment, good review, and just one simple thanks from you people make our day, because money is not the main thing. We have earned enough money, we can live comfortably all life, eating dal, etc. But main thing is your support, your good compliment. They are the main post which are there for us. Okay, thank you very much. Now, next thing, right? What are the findings of hyper? Remember, hyper become cheetah. One line summary. Hyper is cheetah. What is cheetah? Very active, high BMR, very high appetite. Cheetah is eating all the cheeto, खाता रहता, and there is still very slim, very slim. Weight loss is there. High sympathetic, so there's tremor, reflexes, sweating, anxiety, palpitation. Also cannot sleep because of high sympathetic, reflex are more, and doesn't like AC, Rado, AC. Very heat intolerance. Okay, and also there is diarrhea because of increase, so he's become tiger or cheetah. So who's cheetah? Hyper. Hypo is opposite, and there is decrease sympathetic, decreased BMR, obesity, and there is generalized edema called as mixed edema. So mixed edema is seen in hypothyroidism and pre-tibial is seen in hyper, which I'll discuss. Now, Graves is a type 5 hypersensitivity. Very important question. What is Graves? It is which type? It is type 5 hypersensitivity. So type 5 hypersensitivity, and if they give both 2 and 5, I say go in favor of type 5. Okay, now there is hyperthyroidism. This which condition? There is a hyperthyroidism, and there is increased T4 but decreased. Why? It's a primary type. Okay, and it's an autoimmune. There's a formation of LADs. What is LADs? Is long acting thyroid stimulator, which are actually immunoglobulins against the TSH receptor, which stimulate it and cause increased T3 and T4. Okay, and what is the HLA, DR3, B8? HLA, DR3 and B8. Okay, now it is a triad. Or the triad, it has triad of what? You can just remove the lid lag sign. It's a part of ophthalmopathy, lid lag sign. Okay, so dermopathy is there. Or the dermopathy? Pre-tibial mixed edema, which is reddish brown due to deposition of hyaluronic acid. We give steroid to treat this. Let me show you. This is pre-tibial mixed edema. Very common feature. It's bilateral, but plaques are formed, which is golden brown color, reddish brown, and it is due to hyaluronic acid. Okay, treatment is we can give steroids, and yes, it will be corrected. Okay, done. Okay, next question. There is also ophthalmopathy. Ophthalmopathy is because of what? There is degeneration and accumulation of this protein, mucopolysaccharide, and they push the eyeball forward. So that cause exophthalmos, which cause the classical staring look like this, called as the, yes, Scotchers. Scotchers is very commonly seen in Indian locality. When a girl and boy are roaming in park, the local aunties look like this, है ना? So they are staring, कहाँ जा रहा है, किसके साथ जा रहा है, ये local aunties stare like this. This is called as Scotchers. Okay, so it's a Scotcher, auntie looking. So there's also periorbital edema also there, puffiness, chemosis, ophthalmoplegia, diplopia, Dalrymple sign, which is lid retraction. Also is what von Graffe sign. Okay, so many signs are there. Okay, so I don't want to go, that's ophtha topic, but remember eye signs are there. Eye signs are there. Okay, and finally there is goiter, which is hyperthyroidism, bilateral, diffuse, enlarged, very hot. Even broods can be heard. So you can hear the sound because of hypervascular structure. So that is your goiter. Okay, so now treatment. If younger patient, we use anti-thyroid drug. Carbimazole is preferred. By longer acting and more potent. So it is longer and more potent compared to PTU. PTU is short half-life, 1 hour, 2 hour, plus it is not. So that's why PTU is used in pregnancy first trimester. Then old people will remove it. Subtotal thyroidectomy by Hill's operation, or we can give radio iodine ablation with 130. Now thyroid storm is basically increased sympathetic, which can cause arrhythmia, hemorrhage, very severe hypertension, which can cause bleeds also. So that's why we give PTU. So PTU used in two conditions. One is what? Pregnancy first trimester and the thyroid storm. What do we give? We give the PTU. We give the PTU. Also beta blocker are used, propranolol, to decrease the sympathetic, and some books say we can give. I just say plus minus because I have not got good references for hydrocortisone use. Some say decrease the inflammation, some say they are not that effective. So I'll just say plus and minus. Now come hypothyroidism. In India now most common cause is thyroiditis, but poor countries or poor people still suffer from iodine deficiency as the most common cause. But in India now it is not iodine deficiency. Why? Namak ho tata ka tata namak. So because of iodination in India now, iodine deficiency is almost gone. It is thyroid. And remember one, goitrogens. What are goitrogens? They are food which causes the hypothyroidism. Most common are Brassiae family. That is sarso mustard family, which include cauliflower and all these mustards. Now, what is the most common? It is Hashimoto. Remember Hashimoto. It is autoimmune, HLA, DR3 and DR5. DR5. Female are more than male. In fact, most autoimmune female are affected more. Most autoimmune. Okay. It's a type 2 hypersensitivity, anti-TPO, anti-TG antibodies are formed. Histopath Hurthal cells. Remember, Hurthal is seen in Hashimoto. and she is a hasti hui moto. So she is obese because of hypothyroidism, plus she is always, yes, in sleepy and relaxed mood. So that is case. Now first there is clinical features, clinical presentation. First there is hyperthyroidism. Why? Due to leakage of T3. So leakage of T3, T4. So leakage of T3 and T4. Later there is a destruction of gland. So hypothyroidism occur. If it is hyperthyroidism, will give beta blocker and PTU, propyl thiouracil. And if it is hypothyroidism, will give levothyroxine 1.6 microgram per kg per day. And remember, if it is myxedema, will use leothyronine, MCQ. So in myxedema, I'll just write down. And if it's a myxedema, drug of choices, leothyronine, MCQ. IV will give, so leothyronine. So myxedema, treatment is leothyronine. Okay, fine. Now what is the dose? 1.6 microgram per kg per day. Now subacute is basically fever. If they have a fever history, then understand it is D-Quervain. It is which condition? D-Quervain or subacute fever. Some you can have difficulty in swallowing. So that's why if there's a history of throat pain, fever, you should be thinking of the D-Quervain. And self-limiting, you can give NSAIDs for pain and fever, and it is again initially hyper, then hypo, then normal. So that's why no need to give the treatment for thyroidism. So that's why it is the case. In case of riddle is fibrosis of the thyroid, very hard. It compresses the trachea and also esophagus, causing dysphagia, hoarseness. Surgery can be done to remove this gland from compressing the esophagus. And there's hypothyroidism. So treatment is levothyroxine. So let me give a summary. I want you to understand the summary with me. So let's start the summary. If there is hyper, there is what feature? What are the feature in hyper? Increased BP, heart rate, tremor, anxiety, insomnia, weight loss, thin diarrhea. Hypo is reverse. And how do you know? If it is hypo, it is 99%. What? It is what? Yes, it is your thyroiditis. Now they ask you most common. Most common is Hashimoto. And in Hashimoto, what will you see? We'll see antibodies. We'll see antibody, anti-TPO, anti-TG, and sometimes other proteins can be there. Okay, and also Hurthal cell. And it is most common. Okay, and what is the treatment? Treatment is initially it is hyper, then hypo. If hypo, levothyroxine. If it is hyper, we give beta blocker, PTU. Are you clear? Now, if they are having fever, pain, then think of what? Yes, D-Quervain. D-Quervain. No treatment needed, just NSAIDs. If there is severe hyper, we might treat that, but normally it's fever. And if there is fibrosis, no fever, fibrosis, and dysphagia and hoarseness, then it is riddles. And in riddle, we give levo plus surgery if needed. So I hope hypothyroidism is easy now, because 100% one question will come from which topic? From your hypothyroidism. So don't ignore it. It's very, very, very important in this case. So very, very, very important. Okay. Let's come back. Now we come to the neurology. So we are coming to the neurology. Now remember, first we'll discuss headache. Secondary is because of some disease like trauma, most common in young people, or because of anything, meningitis or any tumor. So that's why primary is TMC. So what is the mnemonic of primary? TMC. Secondary is sinusitis. Leave it. So what is primary? It is TMC. Mnemonic is TMC, like Trinamool Congress or anything. Okay, like in Hindi you can make na TMC. Okay. See, carbimazole and methimazole. Remember, carbimazole and methimazole, they are what? Both same category of drug. And what happened? It is carbimazole which convert to methimazole. So that's why no point giving methimazole. You give carbimazole, it is converted to methimazole in the liver. So that's why they are pro-drug form. Okay. Now remember TMC. Okay. Now what is TMC? Tension migraine cluster. Tension. Remember, tension is bilateral, migraine cluster are unilateral, and if there's a crying and red eye cluster, migraine is having Pound criteria. So migraine is Pound. Here cry is there, cry and red eye. So if there's a cry and red eye, it's cluster. If pound criteria, migraine. If tension, it's bilateral and female more than this. Okay, now let's start. First question. Tension is most common primary headache. It is a bilateral condition, female more than male. How to remember? Female take tension more. So remember, female take tension more, and tension occur both sides. Like there's a fight between husband and wife, both are in tension. कि कुछ पंगा ना हो जाए. So therefore tension is bilateral and female more than male. So mother take more tension, father. Mother's always worried, where's my kid? He's eating, not eating. Father don't take tension. Father remove the tension. Like mother is calling the son is not replying. Mother is crying in tension. Father say, what happened? He's not replying and crying. Father say, give me phone. The moment father dials the number, son, Papa, I'm here. So you say, where were you? Papa, I was outside. So that's why father remove the tension. Why? Because father was a son once. So he know where the son is, what the son is doing. Now there's a band-like compression feeling, no nausea, no vomiting. That's why also called as featureless headache. Featureless headache. And what are the treatment? NSAIDs are very effective and they are short-lasting. Mostly they are short-lasting, not for days, short-lasting. Now come cluster. Remember lust. So lust is the mnemonic lust. Who's very full of lust? Boys, including me. So we guys are full of lust, testosterone. Okay, and remember it's a lusty londa. So male more than female. And what the most male do? One-sided love. So it's one-sided. So what males do? One-sided. So it is also one-sided love by guys. So lust is there, one-sided. Okay. Now there are multiple attacks which could be few seconds to minutes, but not more than 3 hours. And it is periodic in nature. Okay. It is a part of your trigeminal, headaches or chronalgias. It is having red eye. All autonomic features. Secretions are increased. So increase secretions. That's why autonomic in nature. So increase secretion due to autonomic involvement. Mainly fifth now. Are you clear? So I hope it's clear. I told na, where you don't use PTU, there we use the carbimazole. Okay, are you clear, Harit? Okay. Now also there is RARA. What RARA? Red eye, retroorbital pain, and there is rhinorrhea, epiphora. There is increased secretion. So increase all secretion. Tears are there, nasal there, and all are increased. So remember, a lusty londa with one eye crying, and one-sided love. That is this treatment. Give triptans. So the treatment is triptans are the treatment plus high flow oxygen. So what is the treatment? High flow oxygen. What the purpose? High flow oxygen cause vasoconstriction. For the purpose, it causes vasoconstriction, and also we give triptans, that is again vasoconstriction and relief. For prophylaxis, we can use CCB. We can use the CCB. Now migraine is the second most common, and it is in female, unilateral female. The criteria is pound. P for pulsatile, also is photophobia and phonophobia, osmophobia. Phobia is there. There is phobia. Then it is 1 day. Can be 24 hours, up to 24 hours. Okay. So 24 hours. Then it is what? Unilateral, nausea, vomiting plus disability. Can't work. So she is disabled, can't do any work. She's so much disabled, cannot do any work. Now, classical. What is the funda about classical? We have aura. What do we have in classical? We have the aura. Aura is sensory disturbances, and it is what? Like tingling, numbness, photo flashes, photopsia or scotoma. Now, pathophysio, this CGRP, that is CGRP is what? It is calcitonin gene related peptide. It causes inflammation and vasodilation on mainly one side. So it causes headache, which is pulsatile. So it's a vascular headache. So it's a vascular phenomenon. MCQ. Okay, so vascular phenomena is there. Are you clear? Biochemistry will take, once we finish this, PSM and biochemistry I have planned. I will take, I promise. I have taken all the subject I promised till now. So obviously some are still left because time window is less. I cannot take 4 or 5 hours. I have to take 2 hours or maybe 2.5 hours. I never get even 3 hours because of so many scheduling issue. Okay. Now, if it is mild to moderate, we give NSAIDs. So the treatment of mild to moderate, NSAIDs are given in mild to moderate. Now, if it is moderate to severe, we use triptans. Now, what are triptans? Triptans are 5-HT1B1D agonist. They are agonist, and they cause vasoconstriction. Okay, vasoconstriction. Earlier we were using ergotamines, which is not used nowadays. And remember mnemonic, one BV, one wife BV, and one dard headache. So that's why one BV, one D. So one B, one D, one BV, और उसका एक ही दर्द है बेचारे को. So one BV, one dard. And we can use valproate also. What do we can use? We can use the valproate. In obese topiramate is preferred. So that's why valproate or even GABA drugs can be used in case pain is not relieved. Prophylaxis, beta blocker, propranolol. So the drug propranolol. New drug is Gpans. We can use Gpan like Olcidipan, Rimegepant. So they are CGRP antagonists. Also we can use the MABs like arenumab or galcanezumab. So they are monoclonal antibody which can be used against CGRP. So arenumab or galcanezumab, they can also be used. Okay. Now we discuss the prion disease. Prion disease is because of an abnormal infectious prion protein, PRP. So abnormal prion protein. Normally they are alpha. Normal is alpha, but what happens? Now they become beta sheet. So normal is alpha helix. But if they are changed, mutated or infected, they become beta pleated sheets, and they cause accumulation and destruction of neuron, and that cause spongiform encephalopathy. So what is formed? Spongiform encephalopathy is formed. Let me show you that also. Okay. So let's see. So this is all exam question. Let's see. So this is your normal protein. Okay. Biggest problem with Windows software is they are highly unreliable. Okay, so let's see. Okay, I'll cover everything, don't worry. Okay, so this is your normal prion. They are alpha helix. Can you see alpha like a staircase? Now they are converted to sheets, and these sheets will accumulate on top of each other, and it causes this spongiform encephalopathy. Spongy is hole-like appearance, so that is caused. Okay, spongiform encephalopathy, and finding is severe cortical atrophy is there, severe, and you see the hockey stick sign or the pulvinar sign. Can you see this hockey stick? So this is your hockey stick sign. Are you clear? Hockey stick sign. Now come back. Now what are the causes? Yeah, what are the types? So what are the types of prion? So prion can cause mad cow disease in animals like cow due to, yes, and humans can get from infected beef. So what is the humans get by infected beef? And that is called as bovine spongiform encephalopathy in humans by eating infected meat. Then kuru is in cannibal, and the most common variant we see in most places like India where we don't eat beef is mainly Creutzfeldt-Jakob disease. So Creutzfeldt-Jakob's, not Jacob, it's Jacob's disease, is the most common variant found in our country. So most common. Now it could be sporadic, that is by some infected meat or food or transplant of organ. Genetic could be mutation of prion protein. And what is the clinical feature? Rapid severe dementia. Rapid severe dementia, and also monoclonic jerks. Monoclonic jerks. So these are the two main hallmarks in this case. Okay, let me finish medicine, then I can start the PSM. If I can't finish medicine, how will I start the PSM? So give me time. Okay, I'm doing my level best. Okay, if I go fast, some people say sir very fast, decrease the speed. If I go slow, I can't cover. So I am like, sir dance karo, dance karke dikhao, ऐसा डांस करो वैसा करो. So let me do at my own pace. I will try to do. If not, I will take a session tomorrow and do whatever left tomorrow. Okay, let me first finish as per target. My target is before 9 p.m. 9 p.m. there's a session again by second year faculty Dr. Parveen, Dr. Nasir for the students. So they've asked me to stop before 9. 8:30, 8:40. So that's why my problem is time issue. And the PDF, this PDF is a golden PDF of medicine, I'm telling you. Okay, it has a strike rate of 70-80% in the exam. Don't ignore the PDF, you will get very good score in this case. Okay, fine. Now in EG we get sharp wave discharges, and an MRI you see hockey stick of pulvinar sign plus cortical ribbing and severe atrophy. Severe atrophy. That is, the sulci become deepened, gyri become thin. Treatment, no treatment, person die within 6 to 12 months. Now come Alzheimer disease. So in Alzheimer disease, there is what? Decreased acetylcholine, and it's due to destruction. It is due to destruction of the cortical cholinergic neuron, which are projections from Maynard's nucleus. So the projection from? They are come from nucleus basalis of Maynard. So the area Maynard. Or the most common lobe, temporoparietal lobe, where the memory is formed, mainly hippocampus. Okay. Next, genetic causes. Remember, ApoE2 is causative, ApoE2 is protective. How to remember? Two people bring us to world. Mama, Papa. Mama, Papa protect. Four people carry us to the death. Four people. So remember, two people protect Mama, Papa. Four people cause the death. So it causes the death. So what protect us? Mama, Papa. So two people protect Ma and Pa, and four people carry to grave. So I'll not write because some people get confused. Those who are listening, understand, four people cause death. When you are dead, four people come, and four people protect us. What are the, sorry, two people protect. What the two people protect? Mama and Papa. Mama and Papa. Now, also there is pre-senilin gene 1 and 2 plus Down syndrome high risk. Down syndrome high. Now finding ha ha, hirano, hippo, he, ha ha. So hippocampus show hirano body, which are inclusion body. Then there's A beta amyloid, which make the senile plaque, and tau proteins make the neurofibrillary tangles. Neurofibrillary tangles. So how to remember? Very simple. Tau. There's a tau who's mentally, having poor memory, and he's Haran Pareshan, Hirano. And he say, A beta amyloid, who's playing on Hero Honda, come inside. So beta playing outside. So plaques are outside the cell, and tau is tangled inside. So it is inside neurons. So what is present inside? Tangles inside, plaque outside. So remember, the beta, A beta myelonda is playing outside, and tangle, tau is tangled inside the house. Tau is tangled inside. Okay, please message me. I will send the PDF personally. Okay, now what are the clinical feature? 4 A's of dementia. So there are 4 A's. Amnesia, that is memory loss. Aphasia, can't speak. Agnosia is knowledge. Gnosis means knowledge. Remember, the word gno means knowledge. No. Remember, and motor performance is faulty. He can't use the object properly. That is called as apraxia. So what is apraxia? Motor performance. Performance is apraxia. Okay. Now, what is the examination? Mini mental status examination. Score will be less than 24 out of 30 in case of what? Alzheimer's disease. Okay. Now, clinical feature, there is decreased memory, decreased speech, which I discussed already. That is 4 A's plus myoclonic jerks, and later it becomes so severe, can't even recognize the family member. And last is what? Which reflexes? The innate reflexes, they will reappear. So what happens? The primitive reflexes reappear. Primitive innate reflexes, they reappear. Like neck reflexes, tonic, moros reappear. And there is no memory. The person is completely dead. He's like a newborn baby. So person become like a newborn baby. MRI, you can see hippocampus is atrophy, plus there is increased size of ventricles, and there is what? It's complete, there's atrophy, which I discussed. Now, drug of choice is donepezil. What does donepezil do? What does? So I discussed that in pharma. Donepezil is the drug which is going to do the wonder. It increases acetylcholine. So what does it increase? Increase the acetylcholine. How? By inhibiting choline esterase. New drug is memantine. It inhibits the NMDA receptor and decrease glutamate excitotoxicity. And decrease glutamate excitotoxicity. MCQ. New drug. Okay. Now come seizure disorder. Seizure disorder. Now in the seizure disorder, what are the findings? First, there is increased electrical discharge from the cortical neuron, and it is, first question, motor feature called as convulsion. What is convulsion? Muscle is contracting. That is convulsion. If more than 2 seizures, then it become an epilepsy. Okay. And most common seizure neonate is subtle due to hypoxia or hypoxic ischemic encephalopathy. Then most common in children, okay, in children with fever is febrile seizure. What age? 6 months to 60. This I all covered in what? I have covered in what? In the, yes, in the pediatrics. Okay, yes. Then there is fever, and after 24 hours there is the GTCS. There is generalized tonic clonic seizure, and treatment is rectal diazepam or IV lorazepam. Whatever sir has taught you, go with that. I will, and also decrease the temperature. So we reduce the temperature. And what is the next question? Prophylaxis clobazam. So what is the treatment? Diazepam or lorazepam, and prophylaxis is clobazam. Now, if it is school going, it is absence seizure. Absence seizure, also called as patent mal. Now, there is no loss of consciousness, no motor feature, no fall, no convulsion, no contraction. That is why it is called as, so that is why called as absence seizure. Absence seizure, okay. Why? Because all the features are absent. So that's why called as absence seizure, okay. So it's called as what? Absent seizure, okay. Now, blank staring. So the child will be like this. So you feel, sir, ये क्या हो गया? Buffer कर रहे हो क्या? Sir, buffer नहीं कर रहे. Sir, सिर्फ copy कर रहे. Okay. So it is like buffering. Okay. So not paying attention, and he is lost. So child is lost. And investigation EEG will show 3 wave and spike pattern. So 3 wave, 3 hertz wave and spike. Okay. You can say hertz. 3 hertz spike and wave pattern. Okay. Now drug of choice. If it is typical, that is no motor feature, ethosuximide is preferred over valproate. If it is atypical with motor feature, we will use valproate and avoid phenytoin. Avoid phenytoin. That's the exam question asked. Why? Phenytoin has a tendency of triggering the absence seizure in this case. Okay. Pharma I have already uploaded in the group. Okay. Please message me. I will send myself. Now come GTCS. Most common in young adults, also called as grand mal. That is a younger child. Okay. Now, first there is loss of consciousness. So the first feature, loss of consciousness. Then there is muscle contraction like this. This is called as a tonic phase. Okay, which is for 10 to 30 seconds. Patient fall down. Teeth is clenched. Tongue bite can occur. Okay, so they are all. Then there is a what phase? Clonic phase. So next is clonic phase. What is clonic phase? There is a relaxation and contraction of muscle multiple time. So that is what look like shivering like this. So this is the what part? Clonic phase, which lasts for 1 to 5 minutes. Now, if it is 1 to 5 minutes, it is GTCS. If more than 5 minutes, it is called as status epilepticus. More than 60 is refractory status epilepticus. Are you clear now? So remember, 5 minutes is status epilepticus, early status epilepticus. 30 minutes is established. 60 is refractory. 24 is super refractory. So what is super refractory? More than 24 is called as the super refractory. Okay. Now remember what the drug of choice? GTCS drug of choice is valproate. Okay. Then we can use lamotrigine, but best is your valproate. Now, if a female is already pregnant and taking valproate, continue valproate and add folic acid 4 milligram per day or 4000 micro milligram per day to prevent neural tube defect. Neural tube defect. Are you clear? But if a female want to be pregnant, okay, then what is the concept? If she want to be pregnant, 30 minutes is your establish. Okay, it is established. Okay, Kavya? If you want, you can take a screenshot. You understand my problem. My problem is, biggest problem is time issue. Okay, time is so less to explain all the concept, and you know, I try my level best to explain to best of my abilities. Okay, otherwise these all things are there and mentioned multiple times by me. Okay, so I will be open that. So let's show you. This is the photo for time window, and remember the period I have discussed. I don't know where it went, because when you need something the most, it is not found easily. This is the case. Look at this. So remember, 0 to 5 is incipient, 5 is 30 is early. This is status epileptic. 30 is established, 60 is refractory, 24 is super refractory. It is super refractory. Please see this. status epilepticus. Okay, so if a female who's having any epilepsy, drug of choice is valproate. So myoclonic or Jan syndrome or atonic, all drug of choice is valproate. Absence, the drug of choice is what? It is what? Yes, for absence, the drug of choice is your yes, ethosuximide. Now question is, let's come back. So if it is already pregnant, we will continue valproate with folic acid. If want to be pregnant, then we will stop valproate and give L drugs. L. So क्या है? वो क्या बोलती है? I want to be pregnant. So you say take L. L drugs are given: levetiracetam, lamotrigine. Okay. Now, what are the treatment of status epilepticus? Right? First is we will start with IV lorazepam. So what is the drug of choice? We will start with IV lorazepam plus phenytoin IV. If not control, we can add IM midazolam. Then we go for IV phenobarbital. Still not control. Then we go for general anesthesia. So the last step, general anesthesia is the last step. Okay. Now we discuss basal ganglia. Very important. So in basal ganglia, first is Huntington disease. It is basically loss of GABAergic neurons from the striatum, which cause increased dopamine and decrease ACH and GABA. So what decreases? GABA will decrease, and there is a triple nucleotide repeat called the CAG repeat. It's an autosomal dominant condition. Age is 35 to 40. Okay, and there's chorea, which is abnormal dancing movement, abnormal dancing, also psychosis, dementia. Now, I will make a very simple summary. Look at the photo, you will never forget. Remember, there is a movie called Sholay. In Sholay, what is the main protagonist? It is Gabbar Singh. Gabbar. So remember the story with me. Gabbar. So Gabbar, GABAergic Gabbar. So it is Huntington disease, and Gabbar carry Hunter with him to hit the people. Hunter. So Huntington disease, GABAergic neurons are lost. And remember, Gabbar make the heroine dance chorea. So Huntington chorea dance. क्या बोलता? बसंती कुत्तों के आगे मत नाचना. तो किसके आगे नाचे? है ना? All males are dogs. तो वो भी तो फिर कुत्ता ही हुआ. छोड़ो. So now hero, he locked the hero in the cage. So that's why cage, triple nucleotide repeat cage, which I discussed already. And what is the age of Gabbar Singh? He is 35 to 40 year age. So age of presentation 35, just same as me. So Gabbar Singh is like me, but I am not Gabbar Singh. Okay. And remember, Gabbar is autosomal dominant. Autosomal dominant. So remember, is very dominant person. Doesn't take order. क्या बोलता है? गोली खा. So he's always taking order. Plus he's psychotic. Keep laughing. Ha ha ha. He's having mania because of excessive dopamine. And he also has dementia. Why? Because of decreased ACH. That's why keep asking, when is the Holi? When is the Holi? कब है Holi? Holi कब है? Dementia हो गया साले को. So that's why remember the story. Gabbar Singh is Huntington disease. That's why he has chorea. Then psychosis, dopamine is increased, GABA is decreased, ACH decreased, GABAergic neurons. Treatment, ban Gabbar Singh. Tetrabenazine. So drug of choice is tetrabenazine. Okay. So I hope you are liking the class and you are able to understand everything perfectly. Okay. It's my small effort to make the entire medicine easy for all of you before the exam. Okay. So now MRI show box car ventricle. It looked like the same car which Gabbar Singh loots in the beginning of the movie. Remember coal? So it carry coal called as box car ventricle due to atrophy of the caudate nucleus. Called as what? Box car ventricle, atrophy of which structure? Caudate nucleus is there. Also there is what? Enlargement of ventricles. So it is enlargement of the ventricles. Okay. Once you get good rank, do inform me. Okay. I will get dopamine. So if you come, I will be happy, and else I will also take my hunter and ban you. Okay. Tetrabenazine. Also we can use valbenazine also. It is also a drug of choice of which condition? Yes, for tardive dyskinesis. So also DOC for tardive dyskinesis, which is side effect of antipsychotic. Also we can use in the Tourette's syndrome. Okay, very good. Now we see Parkinson disease, obviously mask-like face, but main is there's a reverse. It's a reverse of Huntington. It's the reverse of Huntington. You can remember, opposite of Huntington. Now you'll not forget, opposite to Huntington. And chromosome number 4 is the case. Chromosome 4. There's so much information to give, even I get confused what to tell, what not to tell. Okay, fine. Now, Parkinsonism, it is basically lesion of substantia nigra. So dopamine cannot come. So decrease dopamine and increase ACH. What happened in Huntington? Yes, reverse. There is increased dopamine, decrease ACH, and then there is decreased movement, bradykinesia and hypo. That's why the person has very slow and small handwriting. Like I will try to write something, try to read. So I am writing something and you tell me, okay, what am I showing? So look at this. So I will try to write something. What have I written? Can you read? No, you can't even read. You can't even read. Why? It's very small. Now see the magic. I wrote physiology. So that is why I am using micrographia. So what is micrographia? Don't say Lagnira PG'23. So this is physiology. I know it looks bad, but remember I wrote at the level of pixels. Can you see pixels? So this is what I can do. I can write very small. So micrographia seen in Parkinson, but also seen in students before the exam. So some students are doing micrographia in the night before the exam, writing very small chits for the exam. Okay. Now also this decreased blinking, decreased expression, and mask like face like this. Example, examiner. So examiners in the exam have mask like face like this. And they say, give 50 causes of splenomegaly. You can't even say any expression. So that is examiners show what? They show mask like face. Plus there is increased muscle tone, which is extra pyramidal feature. Rigidity is there, cogwheel and lead pipe. So lead pipe, hand is fixed like this. When you try to move, it's very difficult to move. And also cogwheel, which is nothing but jerks or tremors. Okay. Resting tremor, 4 to 6, pin rolling tremor. So it's pin rolling tremor. And remember, tremors are asymmetrical. Tremor asymmetrical. Asymmetrical. Gait is fascinating or shuffling gait. So what is the gait? Gait is fascinating or the shuffling gait which is seen in the patient. Okay. Now pathophysio, Lewy body is seen and it is alpha-synuclein protein. So remember, if there is this, it confirms Parkinson disease. So it is in Parkinson disease and also what? Lewy body dementia. Lewy body dementia. So these are called as synucleopathy. Okay, synucleopathy. Okay. Now for the treatment, a man love Benz car, rolling, gliding, not park. For the mnemonic, yes. Okay. So lead pipe, but that is ulcerative colitis. Okay, Kavya, I'm discussing not the findings of GIT, but yes, you are right. Okay. Now what is the mnemonic? A man. So which man? A man or any man love what? Love car. So amantadine causes increase dopamine release. Then love car. So love is L-dopa, which increase the dopamine, and L-dopa, which convert dopamine, and car is carbidopa. It inhibit the carboxylase enzyme. And what is the result? Increase the dopa. So L-dopa, car. Benz. What is Benz? Benztropine, benzhexol. They are which drug? They are anticholinergic. They are the drug of choice for drug-induced Parkinson disease. Example, antipsychotic. So what is the drug of choice for drug-induced Parkinsonism? It is your antipsychotic drug induced. We give Benz drug. So Benz. Then car is carbidopa. Rolling are dopamine agonists. So they are dopamine agonists. What receptor? Remember, it is D1 receptor. So remember the receptor is D1. I'll just write down D1 here. D1 receptor. Don't forget D1 receptor. ACH is M3, M4. Now question is for the drug ropinirole and pramipixole. One more is there, pramipixole. So ropinirole and pramipixole, they are used. Pramipixole. Okay. So these two are used for this. So pramipixole. Okay. Now question is drug of choice for Parkinson disease in younger patient is ropinirole. If older patient, we will go with L-dopa and carbidopa. Okay. L-dopa and carbidopa. Okay. Now, gillins are your MAO inhibitors, salicylic and rasagillin. Clear? And not park is not. They are ant-capone, tol-capone. They are COMT inhibitors. So they are all the drugs of. I said na, pharma I will cover in CNS. I am covering that. I have covered all the important drugs in cases of epilepsy, in cases of Parkinson and dementia, etc. Okay. So I'm covering pharma also. Now, or the drug of choice is as per Thamim sir material. So Thamim sir, when I ask and I discuss, He said कि in older patients still we prefer L-DOPA, carbidopa, although drug of choice is ropinirole. So drug of choice of Parkinsonism is ropinirole. Older patient mostly are what? Parkinson disease. So we'll use the L-DOPA and carbidopa. What is the side effect? On and off phenomenon where the person completely stops. So drug of choice for on-off is safinamide, which is MAO inhibitor. MAO inhibitor. Okay. Now surgical treatment, pallidotomy, deep brain stimulation, even stem cell implantation, so many new treatments. Now atypical. What's atypical Parkinsonism? They have less tremor and poor response to L-DOPA. MCQ. So if they ask you what is atypical, it is Parkinsonism. There is what feature? This feature of what? What? Rigidity, resting tremor, and the reduction in movement. But there is less tremor and poor response to L-DOPA. First is progressive supranuclear gauge palsy, also called as PSP. PSP is what? Damage to medial longitudinal fasciculus. So medial longitudinal fasciculus. So what is the problem? Problem is patient cannot look down. What is the problem? Can't look down. Now if the patient cannot look down, what is the problem? He will fall down while he is climbing down. So the problem is patient fall down when he look down. So that's why can't look. So problem is spill food, drink, problem in toilet. He go and don't know where to do. So urine will be falling everywhere. So how to remember? He's like Pushpa. Remember movie Pushpa? So Pushpa doesn't bend down. Jhukega nahi sala. So that's why this patient also can't look down. So what is Pushpa syndrome? It is your PSP. Now in PSP, when you do EOG, you see square wave patterns. Which patterns? Square wave pattern. And on what? And on what? On doing MRI, you see the hummingbird sign. Can you see? So this is the hummingbird sign in the MRI. Can you see hummingbird? This is a hummingbird. Now, what is next? It is multi-system atrophy. Multi-system atrophy, also called Shadrager. Here, brainstem is affected. So therefore, it involves cerebellum, which cause ataxia plus Parkinson. Remember, if there is can't look down, it is PSP. If there is ataxia with Parkinsonism, think of multi-system atrophy, MSA. And if there is a dementia in Parkinsonism, you can think of Lewy body dementia. So remember, dementia is most commonly Alzheimer's. Younger person, rapid, think of Prion disease. If it is with Parkinsonism, think of Lewy body dementia. Lewy body dementia. Okay. Now we'll discuss cerebellar lesion. So remember, the main finding is ataxia. So how to remember? Drunken gait. So that is why, remember, when you drink a lot, you should not drive, take a taxi. So remember, drunken gait or ataxia like this. So it's like this. So this is what gait? This is drunken gait. So person is not steady. He keep shaking here and there. It's called what? Drunken gait. And keep falling. Then finger nose. If you ask to touch in finger nose, I can do very fast. But he will do like this. So he will keep missing the target. So this is called as what? This is called as the pass pointing. Also slurred speech is there. How to I'll teach. So he's not able to move the tongue. So that's why there is dysarthria. Also nystagmus is there. Plus there are so many other findings we can see in this test, like dysdiadochokinesis. I'll just write down number 5. Dysdiadochokinesis, unable to do rapid alternate movement. Okay, now comes the question, Friedreich's ataxia. It is both upper and lower. Basically it is sensory lesion mainly. So remember the mnemonic, A taxi में जाओ, fried rice खाओ, और गाना गाओ. So mnemonic is fried rice. Friedreich's ataxia is basically what repeat? GAA. What repeat? GAA repeat. And there is also sensory ataxia like tabes dorsalis. We do the Romberg's test. What we do? Romberg test is positive when the patient stand with hand outstretched and close the eye. He fall down. Why? If he is opening the eye, he is getting a sensory feedback from the vision. When he close the eye, can't see, he fall down. That is called what? Romberg test. So Romberg test is used in what? Sensory ataxia. Example is tabes dorsalis. So this is third type of 1, 2. This should be 3. Okay, 3. Now stroke. What is stroke? It's an upper motor neuron lesion, which is PT lesion, and it is non-convulsive focal neurological deficit, could be motor, could be autonomic, could be sensory. If more than 24 hours, it is stroke. If recovery within 24 hours, it is called as transient ischemic attack. Or if 3 days, that is 7 to 8, it's called as RIND. RIND is 72 hours. RIND is, I'll write here. RIND is reversible ischemic neurological deficit. It is 24. This is 72. So 72. Score is A, B, C, D, 2 score. So we'll use A, B, C, D, 2 score in this case. Okay. Fine. Now, next, stroke could be ischemic or hemorrhagic. Now, if ischemic, it is most common. What is most common? Ischemic. And it is due to thromboembolism. Hemorrhagic is 25. Could be hypertension. If hypertension, most common site is putamen. Okay. And most common vessel involved in stroke is the middle cerebral artery. Which branch? Middle cerebral artery. Striate branches, which is also called as Charcot, which supply the internal capsule. And you know what passes through internal capsule? Pyramidal tract passes. So that's why it causes PT lesion. Let's see the photos. So let's see the anatomy first. So I'm discussing all the anatomical structure. This is basal ganglia. You can see thalamus, caudate nucleus, putamen, pallidus. This is your corticospinal tract. This is substantia nigra and subthalamic nucleus. Subthalamic nucleus. Okay. Now let's come back. Okay. See this. See this. See. This is your circle of Willis and the brain supply. First question. So circle of Willis is having ACA, PCA, and communicating branches. No middle cerebral artery. MCQ. So remember cow. Indians don't eat cow. Cow is mother. So MC. So remember cow is mother. M. So remember in cow, circle of Willis, what is not there? MCA is not there. MCQ. Okay. So this is the circle of Willis. Can you see that? So this is circle of Willis. It include what? Anterior and the posterior cerebral and the communicating branches. What is not included? MCA is not a part. Then this is basilar artery, this is vertebral artery, and then they give the spinal artery. Okay. Second question, blood supply. Let's see. Frontal lobe is mainly supplied by anterior cerebral. The parietal temporal are mainly supplied by the middle, and occipital and cerebellum are supplied by the what? By the what? Posterior cerebral artery. Okay. And next question. This is the areas. So start. So posterior cerebral supply what? It supply which structure? It supply the midbrain. Anterior inferior cerebral supply the pons. Okay, pons. Then basilar artery also supply. Then there is posterior inferior cerebral and the one it's supplying the upper medulla. Vertebral supply caudal medulla, and it is the one which is involved. These two what? In Wallenberg syndrome. So what artery? Vertebral artery is involved in Wallenberg syndrome where ataxia occur. Okay, ataxia also occur. Okay. Okay. Good evening, Pavitra. Okay, and this is spinal cord. Okay, fine. This is your internal capsule, caudate nucleus. This is your putamen. Okay, this is your globus, pallidus, thalamus. All these structures are shown here. This is the parts: anterior limb. This is the genu. This is posterior limb. This sublentiform and retrolentiform. 5 parts of internal capsule. Main supply are striate branches. For the main supply, striate branches are the main supply. In what structure? In our in our internal capsule. Now what are the finding? So this is the case. If there's an infarct, you will see a dark area. If bright light area, it is your hemorrhagic one. So hemorrhagic is bright and dark in CT is your ischemic or infarct. Are you clear? Next question. This is the spasticity where one hand is clasped to the chest like this, called as clasp knife spasticity, and person walk by dragging the body, called as spastic circumduction or sweeping gait. So they are the findings. Okay, they are the findings. Also, there is a positive Babinski's reflex. Normally, it should go down. Normal is down. But if it goes up, it indicates PT lesion. So what lesion? PT lesion. Hallmark is Babinski's positive, also called as extensor or dorsiflexion. Extensor or dorsiflexion. Let's see this. Okay, let's come back. So what are the findings? Clasp knife spasticity. Then there is a spastic gait. Also contralateral spastic hemiparesis is there. Babinski's is positive, which is upward and extensor. That is the case. Now, what are the investigation of choice? NC-CT head, non-contrast CT. Bright is blood, bright. Dark is dead or infarct, dark. Best is MRI, but it takes more time, so we'll prefer NC-CT. Later we can do MRI, and gold standard is cerebral angiography. But they are done only if there is what time available and you are having some suspicion. Okay. Now, what is the treatment? Let's discuss. First is what the treatment we use. We use NIH, National Institute of Health stroke severity scale. So stroke score. So we'll use this, okay, and remember NIHSS, that is National Institute of, we'll use for score, okay, stroke score. And if more than 5, we can go for thrombolysis. So when you do thrombolysis, more than 5, okay. Now, if ischemic, we will do this. Let me teach. First question. If there is hemorrhagic, we will give nimodipine, that is CCB, for controlling the BP. So main aim is control the BP, and we will try to decrease it below what value? Below 140/90. And we can also use labetalol or nicardipine, okay. And nimodipine is mainly used for SAH, subarachnoid hemorrhage, okay. Now, if it is ischemic, do not decrease the BP unless it is more than 220/120. MCQ. So do not decrease BP in ischemic, decrease the BP hemorrhagic, decrease BP by labetalol or nicardipine. In case of ischemic, don't decrease. Thrombolysis is done when the score is more than 5, NIHSS score. Second, thrombolysis can be done, best time is 3 hours and up to 4.5 hours, okay. For the agent, we can use tissue plasminogen activator like ritaplase or streptokinase, Also, we can use low molecular weight heparins. What we can use? Low molecular weight heparins can also be used, like enoxaparin, plus we are giving aspirin, they're anti. So antiplatelets are the main drugs in this case, okay. Now remember, okay, and one small summary I will give, that is, if it is sickle shape, remember EDH is idli shape, and who make the idli? Ma make idli. So Ma is middle meningeal artery. Clinical feature, lucid interval. That is, patient is unconscious, conscious, unconscious. Treatment is Burr Hall craniotomy. So if you see what idli is diagnostic of what? It is EDH, okay? That is middle meningeal. In SDH, which is mainly in boxers, okay, boxers, it is sickle. If sickle, it is SDH, and it is bridging veins, cortical bridging veins. And here treatment is same, but no lucid interval. No lucid. Treatment is again craniotomy. Okay. SH I'll discuss later. SH I will discuss very soon. Okay. Now, meningitis, 100% exam question. What is the concept? Let's start. If age is 0 to 2 months, 0, most commonly it's gram negative E. coli in India. 2 months to 2 years, it's H influenza type B, which is most common. If 2 years, more than 2 year child, it is meningococcus, which is a gram negative diplococcus. It look like what? Bean shape, kidney shape, and rash is there. Skin rashes are there. So what is there? Skin rashes. Okay. Adult pneumococcus, that is streptococcus pneumoniae, which is gram positive cocci in a chain. In HIV, we have what? Most commonly, if they are having cryptococcal neoformans, which look like green, you would say a coin-like structure. So green is cryptococcal neoformans. Okay. Clinical feature: fever, headache, neck rigidity, that is nuchal rigidity, and projectile vomiting. Patient can be unconscious, papilledema, all. 2 signs are there. Kernig, the knee cannot be straightened, it's painful. And Brudzinski is when you lift the head it causes the flexion of the knee. That is called as Brudzinski. They are the signs for neck rigidity or nuchal rigidity. Okay. Now, increase ICP. So in fundoscopy, you see papilledema. Also, this Cushing reflex, high BP but decrease heart rate. Okay. Now, what are the investigation? We will do lumbar puncture, and after lumbar puncture, we give empirical treatment with ceftriaxone and vancomycin, which is third generation cephalosporin. Now, please understand. If there is a low glucose, it is bacterial causes. Can be biogenic or can be TB. MCQ. So if there is low glucose, always suspect what? It is pyogenic or TB. Are you clear? Now, if it is pyogenic, there will be increased neutrophils. There will be increased neutrophil more than 100. Okay. If there is cobweb pattern and lymphocyte, suspect TB, and there is a low glucose, very high protein in gram percent. So remember, if very high protein, cobweb pattern, this is the cobweb pattern. Please see this 100%. This is the case. This is your, yes, meningitis, meningococcus. These are cobweb. Can you see? So these are cob. So nowadays people don't watch TV. They watch web series. So remember, TB, cobweb, and cell is lymphocyte. Cell is lymphocyte. So cell is lymphocyte. And if there is everything normal, then it is viral and lymphocytes are increased. So are you clear? So in virus, what increases? Everything is normal. Lymphocytes are the cell. Very few, just 10 to 25 per millimeter cube. If there is cobweb, high protein, lymphocyte more than 100, then it is TB. And if it is bacterial like pneumococcal or meningococcal, you see neutrophil. So neutrophil is pyogenic hallmark. Am I clear? Lymphocytes can be seen in virus also and TB also. How you differentiate? In TB, cobweb plus high protein plus cells are very, very high. Now, if it is pneumo or meningo, penicillin G is given. It can cross the blood-brain barrier. Pseudomonas cephalosporin can be used. Cryptococcal, we use amphotericin B plus flu, and they are also drug of choice for mucormycosis. And deep, see, even micro I'm covering. So I told you pharma antibiotics are covered. So it is, yes, and deep systemic fungal infection. Deep systemic fungal infections. So what is used? We use amphotericin B. So ampho, I will upload the PDF. Where should I upload? I've given to everyone. Okay, I've given to every group. Okay, so please message me. I will send the file. This is my number. 9899529468 is my number. I will send the PDF. Okay, and in case of TB, we need to give steroids and also ATT. What is ATT? Anti-tubercular therapy. What is ATT? Anti-tubercular therapy. Okay, why? To prevent the adhesions. Okay. Now we discuss motor neuron disease. Remember, it could be upper motor, lower motor, or both. Upper motor cause spastic paralysis. Lower motor cause flaccid paralysis. Okay, flaccid is lower motor, spastic is upper motor. Now, ALS is amyotrophic lateral sclerosis. Here, both UMN and LMN is involved. And how to remember? Remember, in lower limb, it is mainly spastic, upper, lower limb and the body, and in bulbar, face, etc., it is your, yes, what lesion? It is flaccid. So lower is spastic, upper body is showing this. Okay. Next question, normal IQ like Stephen Hawking. So Stephen Hawking suffered from what? Amyotrophic lateral sclerosis, and what he had? He had a normal IQ, normal sensory system, normal ocular movement, and normal bladder bowel control. Only problem is the muscles, the limb muscle, also the muscles of face, etc., bulbar, they are affected. What is spared? Ocular movement by 3, 4, and 6. Also, it's sparing what? Your sensory system. Feature: there is asymmetrical bilateral distal muscle involved and affected. Wasted, can't stand. It's one of the earliest features. And there is what? Bulbar palsy, which involve 7, yes, 9, 10, 11, 12. So what now? 2, 7, 9, not 2, sorry, 7, 9, 10, 11, 12. So it's a LMN lesion. It causes ipsilateral. Remember, ipsilateral tongue deviation. So difficulty in swallowing, chewing, speech, dysarthria is there. dysphagia, dysarthria. Then there is spastic paralysis, mainly muscle wasting is there. Babinski is positive, DTR. They are finding of UMN lesion. So they are UMN. Pathophysio, there is a SOD gene mutation. What is SOD? Superoxide dismutase, which is actually an antioxidant. So without this antioxidant, what will happen? Obviously, it is going to cause what? It is going to cause increase in free radicals. They will damage the motor neuron. So that is why it causes the damage to the motor neuron. Drug of choice, we have riluzole and adaravone. What is riluzole? Riluzole is decreasing excitotoxicity of glutamate, just like memantine, and adaravone is free radical scavenger. It's a free radical scavenger. Now come myasthenia gravis. What is the finding? It's a LMN lesion, autoimmune condition, type 2 hypersensitivity. Okay. And again, what happened? Antibody against ACH receptor, also MuSK and LRP4. They all help in assembly of ACH receptor at neuromuscular junction. So that is why it's what affecting neuromuscular junction. Now without the receptor, ACH cannot act. So that's why there is flaccid paralysis. So it's a LMN lesion, flaccid paralysis there. It is more in evening and exertion, more in evening. And most commonly in female, age group is 20 to 40, and in male it is elderly. So remember Indian movie. So mnemonic is Indian movie. In Indian movie, what is the hero? It is 50, 60, 70 year, and heroine are 20, 30 year. So Indian movie is the mnemonic. Okay. Finding bilateral asymmetrical ptosis and diplopia. So what it affect? It affect the facial muscle first. Snarling face like this. Okay. So there is what? Paralysis, but asymmetrical. One side is paralyzed more, other less. Bulbar involvement will cause dysphagia, dysarthria. Respiratory muscle paralysis in crisis can cause even death. Then normal sensory, normal deep tendon. So reflexes are normal, normal nerve conduction. So here only motor features, not sensory, not DTR. Okay. Then what are the most specific, most sensitive? It is single fiber EMG, but most specific is detection of anti-ACH antibody. Okay. Older tests are ice pack. If you apply ice, ice will inhibit cholinesterase enzyme and increase the acetylcholine. So what they do? They both inhibit cholinesterase and increase ACH. And increase ACH cause what? Paralysis. So Tensilon test, we give IV adrophonium. It's not andro, it's adrophonium. Okay, adrophonium. Spelling is wrong. I told you spelling, please don't worry about that. So it's adrophonium. Adrophonium. So what is the result? So adrophonium, it causes increased ACH, decreased paralysis. Now, drug of choice, choline esterase inhibitor, pyrido and neostigmine. Nowadays we prefer pyrido. Why? It's longer acting. Steroids can be used, and if severe, thymectomy can be done. Then myasthenia crisis, we can remove antibody by plasma pheresis and immunoglobulin, especially against the ACH receptor antibody. Are you clear? Now GBS is the Guillain-Barre or Guillain-Barre, Guillain-Barre. So many pronunciation I have heard, but none of them say it's the right. So it is the Guillain-Barre. It's an autoimmune disease in which there is what? There is what problem? There is problem of the, yes, antibody formation. What are the antibody which are formed? Right? It is against the, yes, it is an infection like in GIT, Campylobacter, but most common is respiratory, which is viral like CMV, EBV, Zika, non-viral Mycoplasma H. So after the infection, there is antibodies formed which destroy the gangliocyte. Like which one antibody? Like GD1A, GM1B or GM1A. So these antibody destroy our gangliocyte, and what is the result of the destruction of the this cells? So what is the result? So result is obviously it is going to cause what? It is going to cause a problem in our body. Okay. And what is the problem we will face or we will have? So what's the problem? Right? Okay. Problem is it causes bilateral symmetrical paralysis. So bilateral symmetrical ascending paralysis. So what is lost first? You will lose ankle jerk, then knee jerk, then you lose the control of the hands and the legs, then sensory feature. So that's why it could be sensory also, motor also, autonomic. So that's why it is what? Sensory, motor, or both, or autonomic. Okay. Auto. Okay. Now come our other finding. So loss of touch, vibration. Most common nerve involved is facial nerve. Okay. In CSF, you see what? Albuminocytological dissociation. That is increased protein but normal cell count. In meningitis, increase in both. In multiple sclerosis, there are oligoclonal bands and there is oligodendrocytes are affected. So what are the finding in multiple sclerosis? Oligoclonal band and oligodendrocytes are affected. Meningitis, increase in both. MCQ. Nerve conduction is the investigation of choice here. What do we see? Decreased velocity, decreased amplitude, increased latency, and abnormal H reflex. Abnormal H reflex. Okay. Treatment: plasmapheresis, IV immunoglobulin. Very good prognosis and recovery occur within few weeks. Okay. Now spinal cord syndrome or the 2 syndrome, Brown Sequard. There's a hemisection of the cord. So remember, there's loss of touch, pressure on same side. Pain is lost in the opposite side, contra. So it's ipsilateral, contra. Tabes dorsalis is neurosyphilis. It is a loss of touch pressure both the side. In lower limb, sensory ataxia is seen. And what is present? Pain is present in syringomyelia. That's a central cord syndrome. Central cord. There is bilateral upper body spastic paralysis. And what is present? There is presence of the touch. What are the main finding? Upper body spastic paralysis. What is absent? Pain is lost in both upper part and the chest. So this is the findings. Okay. Treatment is surgery and we'll try to do. Okay. So let's see that. So this is our what? Syrinx. This syrinx in the case of the syringomyelia compress our spinal cord and the crossing fiber of spinothalamic tract. Once they are compressed, this loss of pain and temperature in the upper part of the body, chest and the hand. But what is intact? Touch pressure is intact. Touch pressure is intact. Okay. Now lastly, I will be summarizing cauda equina and syringomyelia. Use my technique. Remember, conus medullaris. Conus medullaris. I'll rather copy this also. Decrease it. And I will paste it so that my PDF get updated. So let's revise it from here. So use my technique. First question. So my technique is conus medullaris. Dullaris is dual. So it is bilateral. Cauda equina. Vina. Unilateral. Vina is unilateral. Next question. Conus anus. Conus anus. I know the language might sound very odd, but conus anus. So there is, yes, perianal anesthesia. Cauda equina, horse. Cauda equina, horse. So horse, you have saddle. So saddle anesthesia. Next question. So what is unilateral? Cauda. Level is L2 to sacral involvement. And this is L1, L2. So what is L1, L2? Conus medullaris. What is L2 ke baad? Later. It is your cauda equina. So remember, cauda equina, vina, 1. 1 is 1. Unilateral. So what is equina? Unilateral. Conus medullaris. Dullaris is double. Bilateral. And remember, if double, it causes bowel bladder. So that's why it causes bowel bladder dysfunction, impotence, erectile dysfunction. Everything is involved. And what is the anesthesia? Perianal anesthesia. So what is perianal anesthesia? It is conus medullaris. Anus, conus, peri. Okay. So I think it will explain everything. So we'll take a small 5-minute break. Then we'll start the respiratory system. Okay. So 5-minute break we will take. Okay, I will continue and we'll take the respiration. Just 5 minutes. Okay. So can I take 5 minutes? Okay. I'll just drink water and come. Okay, 5 minutes. Okay, 5 minutes. I think I am able to give you very good review of medicine, covering almost all important point in minimum possible time. So just give me 5 minutes. I'll come back and I will cover all the remaining concepts. Just 5 minutes. I'll come. 5 minutes. Let's start. I am back. Please join in. Please join in. I am here. Where are you all? Please join in. Let's start the final session. Okay, so I'm starting, please. I know break took 10 minutes. Okay, but we have to continue and let's start again. Okay, so let's continue. Let's do respiration. And I think what I feel, I'll not be able to cover the entire medicine before the case. Okay, yeah, it's break. Okay, so I hope now you understood the CNS. See, I'm covering everything. Okay, in our medicine file, I have covered each and every important topic. I am not leaving or ignoring. Just 13 pages are left, but that will need another 1 hour, and I cannot take more than that because they have asked me. So let's find a solution to the problem. So what are the solution? So I'll give you two solution. You tell me what will be best. Okay, two solution. One solution is okay. Don't scare about medicine, pharma. What I covered more than sufficient. Do my session. They are more than sufficient for each and every requirement. Okay. So my question to you people. Okay, first. Okay. Tomorrow I wait for their session to be over. Then do today 10 p.m. or tomorrow again there's a session by Dr. Ramya OBG session tomorrow after OBG. Daytime I cannot take. Daytime I'm taking my classes. Okay, so I'm taking my regular batch classes in the daytime. Night I take for you. So that's why there are only two options: today 10 p.m. or tomorrow again after OBG around 9 p.m. I need around 2 to 3 hours. 1 hour for medicine, 1 hour I'll take for biochemistry and PSM. Maybe will take 2-3 hours. So that is the concept. Time is the okay. Okay, Preeti. So I'll ask the team, okay, if possible to make a link and we will do the session at today. I'll ask them, okay, if possible. Yeah. Now I am ready. Yeah, it's not from my side. I am willing and ready. Okay. Okay. Fine. So let me ask the team and we will, yes, create the link and do. Okay, fine. After OBG also, see, today we'll also do and tomorrow also I will take a session. I will do. Okay, don't worry. So I will be taking my sessions because we have what left, 2, 3 and 4 March. March I cannot take because I have a flight. Now only 2 days are left, 2nd or 3rd. So that's why it's either 2nd or 3rd. So I think 2nd I will take today. I will try if they give me link and permission. Otherwise we'll do tomorrow and finish it. Okay. So we are going to rock and we are going to do it. Don't worry. We are going to successfully finish it. Okay. Fine. Let's start. So we are starting the last part. Let's give 100% effort. Now, hypoxia we all know is lack of oxygen to the tissue. There are 4 types of hypoxia. Hypoxic is when the lung can't give oxygen. That is called as hypoxic. Hallmark is decreased PaO2 less than 60 mmHg. Okay, and there's a decreased PaO2, decreased SpO2, and cyanosis is central, which can be seen on the face and the lips. Whereas all other hypoxia, PaO2 is normal. So what is normal? PaO2, like normal PO2, normal SpO2, and there is what? There is decreased hemoglobin, but saturation is normal. No cyanosis, no cyanosis. Stagnant is decreased PO2 or normal PO2, normal SpO2, but peripheral cyanosis occur. This can decrease also. So I'm removing it. Why? Because it can actually decrease also. Saturation is not the right tool. It can decrease. So I just remove it. Why? Not to give any wrong information. Then comes our which concept? The causes is any vascular disease. Histo is normal PO2, normal SpO2, cyanosis is absent. And it is due to cyanide or CO poisoning. They both inhibit complex 4 of electron transport chain. Now, respiratory failure, just remember two types. If there's hypoxia with hypercapnia, it is type 2. If only hypoxia, no hypercapnia, why? The patient is hyperventilating. If a patient hyperventilate, what is the result? Yes, it causes respiratory alkalosis. CO2 washout will occur. CO2 washout will cause what? Hypocapnia. So that's why there is only hypoxia, no hypercapnia. In type 2, the patient has poor respiration. It's a respiratory or you can say breathing failure, respiratory pump failure. So less breathing movement. That's why there is hypoventilation, CO2 accumulation. So there is CO2 accumulation and that causes respiratory acidosis. Treatment is low flow oxygen and correct the ventilator by using CPAP or PEEP or assisted ventilation, anything. In that case, causes it's any severe obstruction or poor respiratory movement, severe restriction, chest wall injury which cause restriction, and high flow is contraindicated in this case. Are you clear? And then even what late COPD, not early but late COPD. Now, in case of anything which affect the diffusion, so here what is the problem? Diffusion is the main. So poor diffusion, VQ mismatch. So they cause what disease? They cause our type 1 respiratory failure. The breathing is okay, rather patient is hyperventilating, but because of the poor diffusion, oxygen cannot go to the blood. So treatment is 100% oxygen, high flow is given. What is given? High flow oxygen, and causes early emphysema, asthma, ARDS, ILD, COVID-19. They all cause type 1 respiratory failure. Now, there are two kinds of obstruction, fixed obstruction and the variable. In fixed, both inspiration and expiration are poor. So what is poor? Inspiration, expiration, both are poor. So what is poor? Both inspiration and expiration. Are you clear? In variable, what happens? In variable, if expiration is poor, okay, wheezing sounds would be there. So what sounds are there? Wheezing sounds are there. So what sounds are there? Wheezing. And if inspiration is poor, there is sound in the stridor. So that's why it is extra thoracic obstruction. Remember, if there is poor inspiration, it is extra thoracic. If it is a poor expiration, like wheezing sounds are there, it is your intrathoracic obstruction. It is variable intrathoracic obstruction. Example, COPD, asthma, or if there is a diphtheria, tracheomalacia, laryngomalacia, it is variable extrathoracic obstruction. Investigation, flow volume curve. Normal curve will show you triangle at the top and hemicircle at the base. I gave a mnemonic. It looked like a happy face. So a happy face, birthday boy. So triangle is what? The mountain of expectation. Face is a hemicircle. It's what disease? It is normal. But if there is a problem in the triangle, it's a poor expiration, like this triangle is blunted. If triangle is blunted, what is the diagnosis? Diagnosis is variable intrathoracic obstruction. Now, if there is a poor inspiration, it's a variable extrathoracic obstruction. The diagnosis is a variable extrathoracic diagnosis. So it will be like this. Okay, so I'll make a simple one. So this is your, yes, variable extrathoracic. And if both are affected, it look like a closed lips. So this is the concept. So this is fixed obstruction. Are you clear? Now, in case of lung disease, there are two kinds of lung disease, restrictive and obstructive. In obstructive, there is narrow airway, and that's why air is trapped, which causes the increased lung size, increased RV, and because of the obstruction, the FeV1 percentage will be decreased. But what can be normal? Compliance can be normal. So compliance can be normal. Are you clear? So what is normal? Compliance is normal. So what is normal? Compliance is normal. Okay. Now what happens in restrictive? There is poor compliance. So what happens in restrictive? Tell me. In restrictive, there is what compliance? Good or poor compliance? So there is a poor compliance, and there is also decreased size of the lung. Then all the volumes are decreased. All the volumes are decreased, and there is normal FEV1 percentage. So that is why the best investigation to differentiate restrictive from obstructive is FEV1 percentage is the best investigation. So the best is FEV1. Less than 80% obstruction, 80 above is restriction. Now in obstructive we will give salbutamol, that is beta 2 agonist. If there's a bronchodilation, that's a good response. It's a reversible obstruction like asthma. If poor response, it is an irreversible obstruction like maybe a chronic bronchitis or emphysema. Okay. Now asthma is a type 1 hypersensitivity, allergen, pollen, anything. It will trigger the reaction by binding to IgE antibody, then cause the histamine release and also leukotriene C4, D4, E4. From what? From the mast cell and eosinophil. So what is the release? Eosinophil, this, and it causes bronchoconstriction, which causes the wheezing sound because of variable intrathoracic obstruction. On sputum we see 3C, CCC. What 3C? They are Crayola body, Charcot-Leyden, Cushman spine. Spelling is not correct. It's Cushman. Okay, so it's Cushman spiral, not this. So Cushman spiral is it. So Cushman, let me show you. So these are the finding we will be seeing or having in this particular case. Are you clear? So Cushman spiral are there. Next point, what are the other changes we will also be seeing here? So this is the flow meter we use. These are the finding. So Cushman spiral, Charcot-Leyden, and Crayola body. So Cushman, okay, Cushman. CU. Okay. So Cushman, double. So Cushman spiral, Charcot-Leyden crystal, and Crayola body. Okay. These are the three finding. Spiral look like a thread. So it is a thread-like structure. Charcot-Leyden are made by galactin. So it's made by galactin 10. So it's what? Crystals made by galactin. You can see this. So galactin 10 is a protein for Charcot-Leyden, and they are basically derived from, yes, degenerating eosinophil. And this thread-like structure is basically your Cushman spiral. Cushman spiral, not Cushman, Cushman spiral. Okay. Now, next question. Okay. What is the treatment? First is prophylaxis. Prophylaxis is we prevent the exposure, and we use immunoglobulins, antibodies, like example omalizumab. So make a mnemonic, very simple. Okay, so you go to a garden and there's a mali, you say oh mali, stop, don't release the pollen. Me pollen allergy, me polizumab. And you say why you are in the garden, you say rasila aam khane aaye, raslijumab. So they are what? They are monoclonal antibody, mipoli, resli, and omali. So where is mali present? In the garden, and garden you are going for mango, and that's, and what they inhibit? They inhibit interleukin 5. So what do they inhibit? They inhibit our interleukin 5. So what interleukin 5? And what is Ig antibody MAB? It is omali. Also we can use mast cell stabilizer, which are nidocromil or the chromoglycate, sodium chromoglycate. They are mast cell stabilizer. Okay, masti na karo, chromoglycate. Then we can use leukotriene antagonists, which are montelukast or zafirlukast. So they are doing what? They are leukotriene antagonists, block the leukotriene from acting C4, D4 and cause bronchoconstriction. Then antihistaminic we can use cetirizine, levocetirizine, or we can use LOX inhibitor like ziluton. Ziluton can be used. Ziluton. Let it be there. So ziluton can be used. Now, in attack, we use a reliever. So who is a reliever? Bronchodilator is a reliever. SABA or LABA. SABA or LABA. LABA is used if there is a persistent condition. Now, steroid are the main drug. So the main drug for the treatment of the patient. Steroid are the main control. So they are the controllers. And what they are? They could be inhalational like budesonide or fluticasone. Side effect, candida. oral candidiasis. Okay, oral candidiasis. Okay, for diagnosis we can use right peak flow meter. If it is less than 250, it indicate a poor flow rate. So this is the right peak flow meter. If you are getting a flow rate less than 20, it indicate your obstructive condition. What the condition is? Obstructive condition is less than 20. Less than 20 is there. Are you clear? So less than 20 is obstructive condition. Are you clear? Now question, what the diagnosis? Decrease FEV1. Less than 80 is mild, 50 is moderate, 30 severe. How to remember? 30 plus 50 is 80. That's it. So 80 less is mild, 50 less moderate, 30 less severe. Mnemonic done. Intermittent is when you are affected less than 2 nights or 2 days and 2 nights. Less than 2 nights a week. So this is a month, sorry. 2 nights is called as what? Intermittent. So less than 2 days or 2 nights a month is called as your intermittent. Are you clear? Then what do you give? SABA is the reliever and inhalational steroid as a control. If it's persistent, it's called as more than 2 days a week. More than 2 days a week. And we will use basically LABA. Okay, we can use a LABA or LAMA with ICS and prophylaxis. In severe asthma, what is the preferred treatment? So if the severe asthma, that is almost multiple attack per day. Severe is multiple attack per day. Then what do we do? Severe, I just corrected, is multiple attack per day. Then we use oral steroid. So we use the oral steroid. Now in status asthmaticus, it's a silent chest. The child is not responsive, respiratory or breathing movements are absent. Then we start with humidified oxygen, nebulization with salbutamol and iprapropium. Also we give subcutaneous terbutaline, IV hydrocortisone and theophylline. This is treatment for what? Status asthmaticus. And remember, there is a Brittle's asthma, which is basically what? Brittle's asthma. So in brittle asthma, there is what? High PEFR variability and poor response to treatment. And here treatment is basically will go for steroids or adrenaline. So treatment is steroids, IV can be used, or adrenaline. So that is used in Brittle's asthma. Okay. Now COPD. COPD is 2 types. It is either blue bloater, which is bronchitis, or emphysema, which is pink puffer. In emphysema, there is a poor diffusion. So person is having, yes, respiratory distress, hyperventilating, and the chest is barrel chest, or also there is pink puffer. Why? Because of increased RBC. Whereas in a patient with bronchitis, here is cyanosis and plus obese. So he is a blue bloater and he has cough with copious sputum more than 3 months for 2 consecutive years. Not alternate, it should be consecutive years. Okay, consecutive years. Now, etiology, smoking or pollution, which cause the inflammatory response. First, damage to the ciliary epithelium cause reduced mucociliary clearance. So stasis of the mucus is present, and that will start making mucus plugs and obstruction, which can cause increased infection. So this can cause infections. Then there is also squamous metaplasia, which can cause squamous cell cancer, SCC, and there is also increased mucus production due to hyperplasia of gland, and that cause cough with copious sputum and hyperplasia. Also there is an increase in goblet cell. So increased goblet cell proliferation is one of the findings. Okay. Now for the diagnosis, read index is 5 or above 5. 5 or above is hallmark of chronic bronchitis. Now what is read index? Is actually ratio of mucosal gland with the bronchial wall thickness. This is the concept. Okay. So normally what happens is the glands are less than 40%, that is 0.4. So what is the ratio? If you take from basement membrane to the perichondrium where cartilage start, this thickness, wall thickness, and the gland layer should be 40% or less. But in case of what bronchitis, there is a hyperplasia. Hyperplasia of the gland will create what? Increase in the ratio. So now it is, see, this is normal, This is increase more than 0.5. That is called as a Reed index. Also, this is a normal airway with all the glands and the epithelium intact. Here you can see first hyperplasia of the gland, muscles are also increased. Also, this what lots of sputum, you can see it's coming out, and this causes narrowing of the airway. This also show a diagram where goblet cells are increased. You can see plus cilia is lost. Loss of cilia cause the mucus to not move and rather accumulate, causing the mucociliary clearance reduction and stasis, and also stasis. Okay. Next question. What is the findings? Clinical feature, there is a history of smoking, plus there is a blue bloater, that is cyanosis is there, and also cough with lots of sputum. Cor pulmonale can occur, which causes the right-sided heart failure. So what is right-sided heart failure? It is seen in COPD. Infection is there, clubbing can be there, dyspnea is there, respiratory failure type 2 occur. Why? Because of poor respiratory movement, severe obstruction, wheezing, rhonchi or wet sounds. What is rhonchi? They are the wet sound, khar 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 sounds. Okay. And spirometry will cause decrease FEN percentage, but normal compliance, normal diffusion, normal DLCO. Problem is in airway, not in the lung per se. So that's why the diffusion, the alveoli are all okay. So that's why compliance, diffusion is okay, airway are affected. Treatment is stop smoking. Drug of choice is varenicline. So varenicline and nicotine gum or patch can be used, but drug of choice is varenicline. Antibiotics, mucolytic like bromoxine, ambroxol, and acetylcysteine, steroid and bronchodilator. But main treatment is stop the smoking. Now, emphysema. In emphysema, there is a damage to the elastin protein because of what? Excessive increase in the elastase. So what is the increase? Increase elastase is the concept. So what increases? Elastase will increase. Now, what is the most common cause? Most common cause is the cigarette smoking. What is the most common cause? Cigarette smoking, and it is centri acinar. So the type is centri acinar type. Okay, and if there is a parents give, that is genetic disease, it's a congenital emphysema due to alpha-1 antitrypsin deficiency. So it is pan-acinar. So remember, parents give is pan-acinar, cigarette smoking is centri acinar. Let me show you. So this is emphysema types. So this is normal acinine. Normal acinine start from the respiratory bronchiole and all the alveoli connected. Now this is normal. This is central part, centri acinar, and this is whole of the acinus dilate. This is pan-acinar. So pan-acinar seen in which condition? Pan-acinar is seen in alpha-1 antitrypsin deficiency. Centri is seen in cigarette smoking. Cigarette. And chest become barrel shaped. Why? Because there is air accumulated. High compliance with poor recoil cause the air to accumulate in lung. The chest become barrel shaped, plus the lung develop lots of bullae, bleb or emphysema. So these bullae are basically subpleural. Sometimes they rupture and cause what? Closed pneumothorax. So what they can cause? Closed pneumothorax. Not open, closed pneumothorax. MCQ. Done? Then what is the X-ray? X-ray will show hyperinflated lungs feel, hyperinflation, diaphragm is flattened and depressed. Then there is hyperlucency, heart appear very small, tubular vertical heart. Can you see? The heart look almost very narrow. Then also there is what? Avascular zones, which are, you can see, no blood supply. Then there is also, even you find this, okay, the lungs cover everything, even the clavicle is hidden because of the prominent lungs. Okay, now finding I told you already, there is air which is not coming to barrel chest. There is also high pulmonary resistance because of damage to the blood vessel, which can cause pulmonary hypertension and right ventricular hypertrophy and heart failure, called for pulmonary. Then there is poor oxygen diffusion, which cause RBC to increase, causing polycythemia. Person is hyperventilating with pursed lip breathing, with narrow lips, and that is called as the pursed lip breathing, which also I will show. The benefit of pursed lip is what? It improves the expiration. It improves the expiration by increasing the backward pressure. When you narrow the airway, pressure increase. This pressure open the airway, allowing better airflow. So that's why it's causing pursed lip breathing. Okay. Then what is the treatment? We will do stop the smoking, antibiotics, same as what? Same as bronchitis. Same as bronchitis. Later we can do bullectomy, lobectomy, pneumectomy, lung transplant. And the criteria is Bord's index, which is for, yes, our BMI, obesity, then exercise tolerance, that's the case. And 7 to 10 score is required in this case. Okay. And let me show you the final comparison. It is called as the bronchitis versus emphysema. Can you see that? So there's a finding. Who's a younger one? Bronchitis is 40-45, emphysema is older, 50 plus. Dyspnea is less in bronchitis, more in emphysema because of destruction of alveoli and poor gas exchange. Then infection, sputum, cough, airway, more in bronchitis, alveoli, diffusion, dyspnea, compliance, barrel chest, more in emphysema. So that is the case. And finally, his lungs are hyperinflated. His lungs are normal, but they are having basically prominent vessels and large heart present. Okay. Last we see is bronchiectasis here, because we have to finish it. Next session is going to start. So bronchiectasis is irreversible airway damage. Dilation of airway occurs. That's called as ectasia. Most common site is mainly left lower lobe. In India, most commonly infection cause. Worldwide, it is cystic fibrosis, which is a chloride channel defect in autosomal recessive condition. Thick secretion, CFTR gene, cystic fibrosis, transmembrane conductance regulatory gene. Obstruction occur in the GIT, infections are there, jaundice is there, sweat test chloride is increased, more than 60 milliequivalent per liter. Treatment, mucolytic and new drug, ivacaftor. What is ivacaftor? It is regulating the chloride channel, CFTR. What is ivacaftor? It increase chloride channel activity and increase the secretions to have more fluid. So what is the secretion? Thick viscous secretion. Okay. Lung transplant can be done in the end. What is carcinoid syndrome? It can also cause bronchiectasis. And carcinoid, there is a abnormal axonal dynein, which is cilia. So that's why ciliary motility is affected, which cause bronchiectasis, sinusitis, and dextrocardia, which is called as situs inversus, and also infertile, also sterility. So cannot have baby, sterile is there. Okay, sterility is there. Finally, what are the findings? There is cyanosis, clubbing, cough, and what kind of sputum? Mucopurulent sputum. On HRCT, you can see dilated airway, and pain is signet ring, which is a pearl ring, and also tram track appearance. Let me show you signet ring and tram track. So this is the finding. So they are clubbing. Can you see the clubbing? This is a severity scale for dyspnea. This is the CAT scan. There is COPD assessment test. Now this is your signet ring. Can you see? So there is the ring which you can see. The black is the one and the white is there. It looked like this. The black is the air, white is the airway. So that is looking like a pearl ring. Here you can see it much more prominently. This is your tram track appearance. So it's like a railway track, curved lines with septa-like structure like this. This is called as a tram track appearance or railway track, you can say. And this is your, yes, HRCT showing dilated airway on the one side. Are you clear? So this is your what? Bronchiectasis. Treatment is similar to bronchitis, but don't use what? Steroids. So we use antibiotic, mucolytic, oxygen therapy, lung exercise, or physiotherapy. But what we don't use? We don't use the what thing? We don't use our, yes, what thing? Yes, we don't use our steroids much here. Okay, clear? So I'll be ending here. Okay, so next session I'll be taking some of the pneumonia also and the CVS with acid base and ECG. So I'll take 1 more hour to cover the remaining medicine. In today almost 2.5 hours I've covered the 3 major system, that is respiration, CVS, not CVS, CNS, and the endocrine. Okay, so I'll be saving this file for all of you to use. So I'll save and close. So I'll be uploading it in the app so that you are able to use it for your revision. Okay, so I'm ending the session because problem with me, not with me, but system is 9 p.m. another session will start. If I don't finish, the other session will not start. There's a Zoom session by Dr. Praveen, Dr. Nasir. Are you clear? So please attend that. It is very, very important. Okay? So let me wrap up. Okay, thank you very much to all of you for joining. I wish I got today whole day, then I would have covered all the medicine and even done PSM and biochem. PSM I'll just take 1 hour. I'm telling you, PSM 1 hour and 1 hour for biochem. So total we need 3 hours. So 3 hours we need for our this. Okay, so see 3 hours. Okay, 1 hour for medicine, 1 hour PSM main concept, mainly epidemiology and biostats I will cover. So biostats and epidemiology, 1 hour I'll take for biochemistry. Okay. Yeah, let me ask them. Okay. I'll ask them and then you will get notification. Okay, clear? So if you get a notification, you can see, otherwise you can message me. I need to update you. Okay, so I'll update you if available, otherwise I will just wrap up the session. Okay, I hope you were able to learn medicine in this short window. Clear? When I normally take class of medicine, I take 70 plus hours and I cover in detail more topic and better. I'm just doing a revision, so I'm taking just ECG. कहाँ से कराऊं मेरे भाई? अगर time मिला तो I'll पक्का do ECG because I need 1 hour for ECG, 10 minutes. Okay, I'll do all the ECG. Already I prepared all the ECG slide. I just need time window to do the ECG. Can you see this? This is my all ECG slides. This is the all ECG slide. Arrhythmia, MI, evolution, all the finding. So I just need what 1 hour to cover ECG and cardiovascular system. Even I made a very good slide for murmurs and how to solve the question of murmur. Okay, chalo, I will wrap it up. Okay, after 10 minutes they will then abuse me. Chalo, take care. Bye bye. Let's meet soon. Thank you for joining. All your support is crucial in me conducting these classes. Otherwise I will be very bored and not even willing to continue for a second. It's just because of you people I keep taking session and keep teaching you. Okay, so thank you very much. Let's meet tomorrow and we will do and discuss everything. Take care. Bye bye. Thank you very much. Thank you to everyone. Yeah, it will help in all the exam. Okay, so chalo, take care. Bye bye.